Good morning, everyone. I'd like to thank everyone around the county for tuning in and watching the Pediatric Symposium today. I'd like to particularly thank Dr. O for putting this together and allowing us the opportunity to be educated. And I'd like to thank the other physicians for sharing some of their very valuable time with us. Our plan today is to go from 9 o'clock to about 1 o'clock. If you have any questions, please feel free to ask them over our YouTube link. And with that, I'm going to hand the microphone off to Dr. O.
Thanks, Joe. So I wanted to introduce this morning Dr. Vicki Sakata, who hails from Colorado. She is the Senior Medical Advisor for the Northwest Healthcare Response Network and truly has been kind of leading our state's response to COVID. She did her training at Madigan for emergency medicine and has been a member of the Washington DMAT team since 2001. Without further ado, Dr. Sakata.
Hey, thank you, Lila. Appreciate it. All right, good morning, everybody. Once again, in the land of this new, way of doing things, we're here, and we're really happy that all of you are joining us. Hopefully, somewhere comfortable, although we know it's a difficult time. So, I hope you can participate. Please feel free to. I think you have the capability of putting in questions as well online, and as you ask questions, I'll certainly stop and try to address them. My talk today, I've been asked to give a little bit of a COVID update. It's certainly not specifically to pediatrics. It's really a lot about COVID in general. And without further ado, we'll just kind of get started. I'm going to give you just a little bit of perspective. Also going to give you a little overview of the current state of the county here, of our state, and definitely of our country. I'm going to jump right into this aerosol droplet problem that we're having. I'm going to talk briefly about the crisis standards of care for EMS, and if you're sitting around waiting to hear about the crisis standards of care EMS plan, I would suggest that you kind of go take a break and put the laundry in the dryer, because I'm not going to talk a whole lot about the Crisis Standards of Care Plan, except to let you know that a lot of great people are working on EMS Crisis Standards of Care. And then I'm going to focus on the end a little about pediatrics and COVID. So without further ado, I do want to give you a little bit of perspective. It's very rare nowadays that every day you wake up and you hear about health news. Every day you wake up and you hear about the number of new cases of a disease. Every day you wake up and there's something about COVID, there's something about illness, there's something about how this virus spreads, and how many people are sick and how many people are dying. So I'm just going to show you a few numbers just to kind of give us and remind us of perspective on this. This is the top 10 causes of death according to WHO. And I also remind you that, COVID now, we have about 200,000 deaths in the US. But if you look at, let's see if I can advance. If we look at other numbers, for instance, annually, globally, there's 15.2 million deaths a year for ischemic heart disease and stroke. There are over 3 million deaths a year because of COPD. There are, millions of deaths every year from lung cancer and diabetes. If you look at other infectious diseases, for instance, diarrheal diseases, which I will tell you, children are suffering the most and dying the most globally from diarrheal diseases. There's over 1.4 million deaths a year just on diarrheal diseases, okay? I will remind you of another virus that was creating havoc many years ago. It's called HIV. HIV epidemic started in the 1980s. There have literally been 33 million deaths since the start of HIV. And is there a vaccine for HIV? There's no vaccine for HIV, okay? So just giving you a little perspective here, 1.4 million deaths a year because of just traffic accidents, okay? And it's not, I just wonder, I sort of ponder this. If we woke up every day and said, another 3,000 people died because of smoking and ischemic heart disease and stroke, I just wonder, what that would change about our healthcare system. So just keep that in mind. I also want to remind you a couple other numbers. Does anybody remember this number that we heard about? Sorry. The top number of 80%. Back in January when this started, the number that was given to us is that 80% of cases are mild. Okay, 80% of cases are mild cases of COVID. That second number, 92%, that is the number in the state that I describe as mild cases. Okay, my definition of mild is the number of cases that did not require hospitalization. So as you look through the numbers on our state website, and you take the total number of positive cases, and you divide the number of hospitalizations by the total number of cases, you get that the hospitalization, the number of moderate diseases and deaths is about 8%, 7 or 8%. So that means that 92% of cases of COVID in our state are mild cases. Again, just giving you the numbers. So if you go county by county and through the state, you guys have obviously seen these kind of graphs. Pierce County, this is about Pierce County, and as you can see, it's very interesting. Pierce County had a bump in the spring and a bigger bump just recently in the summer. This is completely opposite from like King County. King County had a very large spike in the spring and a smaller bump this summer. If you look at the state numbers, you're looking at the number of cases. Again, in the spring it's here, in the summer we're looking at higher number of cases. But that doesn't mean that there has been a higher number of deaths or hospitalizations. That's because we had more testing. So again, the number of hospitalizations was much higher in the spring than it is currently. And the number of deaths also was much higher in the spring than it is currently. And in fact, is tapering down significantly throughout the state. Some interesting data about the ages of patients that are being affected by this disease. Male and female, about the same. The age groups, however, have completely switched. So currently, the 20 to 59-year-old age categories are the highest incidence of disease. Okay? Back in the spring, this was completely opposite. Now I want you to compare this graph to the number of people or the ages of people that are being hospitalized. The ages of people that are being hospitalized are still high. Between the 40 to 80-year-olds is the highest number of cases being hospitalized. Sorry to my cameraman because I keep moving, right? So the hospitalizations are still affecting the older population. The deaths as well are still affecting the older population as opposed to the number of people that are getting cases, which is actually the younger population. So if you look at, also there's been a lot of discussion about equity, race and ethnicity, and those sorts of populations that are being affected, and we certainly are completely aware of that throughout the state. If you look proportionally, Hispanic, Pacific Islanders, Native Americans have proportionally been affected more in this disease than other ethnicities, and we continue to keep track of that and continue to really focus our public health efforts on those vulnerable populations, which is very, very important. If you look really throughout the United States, Washington State is actually doing quite well. Washington State has a lower number of cases per 100,000, just numbers of positive cases. Also has the lower number of deaths per 100,000 as well. So as you look at all these numbers, and we always talk about what is the future. How many times have you heard about the fall? The fall is upon us, and respiratory season, and what's going to happen. I personally am choosing to look at this as the bottle half full instead of the bottle half empty. I am choosing to be optimistic about this fall, and let's just say you heard it here, that the fall hopefully is not going to be as bad as what we experienced in the spring. And I say this for several reasons. I say this because of what's here on the screen. We have testing. We have testing, and that's huge. The reason we had such an incredibly bad spring is that we were hand-tied and had no testing. There was numerous cases that were in our area and in our state that we could not identify, and therefore we could not isolate, quarantine, contact trace. All that is helping us keep this pandemic under control in our area. We have testing now. We have a really strong, kudos to our public health partners. Send your public health partners a thank you message because they are working overtime in identifying, contact tracing, monitoring, because that is what's going to help keep this under control. And, first and foremost, the reason that the fall is not going to be as bad is because we know what to do. We have, quote unquote, the cure for this problem. And the cure is this and distancing. All right? You guys who are watching this over the web cannot see, but there's 1, 2, 3, 4, 5, 6, 7, 8 of us in this room. We're all 6 feet or more apart. We all have masks on. The surfaces have been cleaned, and no one is touching their face. So that works, okay? This works. Masking works. Social distancing works. And if you question that, I would show you this graph, all right? You need to follow IHME. This was us back in the spring. For those of you who were watching this on the web, back in the spring, before we put in any restrictions on social distancing, this line was going to go like this, way up. And this is what they're predicting as well. This line, if we don't do any masking, any social distancing, is going to go like this. But if we do, it's going to go like this. So I think the fall, if we all do our part, is going to be okay. I think the big question will be this. Do we as a society, do we as responsible people in this world, do we have the will? Do we have the patience? Do we have the perseverance to really care for each other? Because we know we have the cure in hand, and it's what we're doing right now. Now, the cure kind of sucks. I mean, we are a community, and we are people that want a pill to solve our problem. We want a shot to solve our problem. We want to get on with our lives. We don't want, we want our kids to go to school. We have an agenda. We have a schedule. And yes, this whole thing is a complete disruption and, just unpleasant, shall we say. So, the inconvenience is there for sure. But I think we do have reason to believe that we can keep this under control and keep our family and friends and high-risk people healthy in our hands. Okay, so I just wanted you to keep that message and question in hand. We're going to talk briefly about, is this an aerosol? Is this a droplet, right? How many times do we have to think about this? All right, the case of the missing web page, right? The web page goes up, the web page goes down. Oh my gosh, what is everybody doing? What does the CDC mean? Well, it's a mystery. All right, so, and how many times do I have to see this? Every time I see these pictures, I want to take a distance and wash my hands. I have the answer for you, all right? This is the answer. Is it an aerosol? Is it a droplet? The answer is this. It's both. We know the science. We know the science. We know that it spreads by large droplets that drop, within a few feet of each other. We know that it can spread a little bit farther. The problem being is that, when you talk about infection prevention and infection prevention measures, we have developed these 4 boxes that we like. We like to put things in boxes. We have standard precautions, we have contact precautions, we have droplet precautions, and we have airborne precautions, right? This is what COVID is doing. We need a box that's airdrop because that's what COVID is. It's an airdrop disease, okay? There are some times that it can be aerosolized. There are some times that it's droplet. It doesn't fit in our nice little boxes. I'm sorry, it doesn't. But that's just the nature of the disease. And I also want you to remember other very basic infection ID principles. in order for you to catch a disease, there's a degree of contagiousness, this R naught or this R effective that we've talked about throughout this pandemic. And the R naught and the R effective is like, how many, if I have COVID, how many people can I infect? And for measles, you already heard measles. Measles has a huge R naught. If I have measles, everybody in this room is guaranteed to get it. I mean, it has an R naught of about 12 or something. That's horrible. The R naught for COVID right now is almost less than 1. It's like 1. Hooray, hooray. Because of why? Because of this. Because of this and social distancing, okay? The other thing is the dose response curve. This whole argument about aerosol, not aerosol, you know, whether or not you cause a disease is if you get a high enough dose of the germ inside you, and the germ has to be actually contagious and cause infection. That's the other thing that everybody's arguing about. You know, so I can find particles in the air. Are those particles viable? Well, we don't know. That science is not completely out yet, although I hear there's articles to be published soon. But, you know, I think we need to stop worrying about this. We need to stop worrying about this. And the reason we need to stop worrying about this, I mean, we do worry about it because of how do we protect ourselves? How do we protect public? How do we protect healthcare workers? And the reason we need all these scientists to quit worrying about this is because what we need to worry about is we need protection from it, especially those of us who are frontline people, those of us who can't avoid potential aerosolizing generating procedures, who have to be up close to people who are ill. We need protection of it. And so the protection that we have are PAPRs and CAPRs and N95s. And again, you will hear this from me and for many others, we do not have enough N95s, period. There's a shortage still of N95s. And so what we need all these scientists and engineers and manufacturers to do is actually make us more N95s. Okay, we just need more N95s for those of us who are frontline that have to do these procedures. If everybody from LNI or the government or CDC or WHO, if they want to protect the healthcare workers, they need to find a way to make us more protection. And it's also a responsibility of us that are in healthcare. We have a responsibility to understand and know how to use an N95, a CAPR, and a PAPR. I cannot tell you how many times I have seen healthcare workers not do it correctly. You know, if you don't handle your N95 or your respirator correctly, you will infect yourself. Okay, so you need to go, oh, by the way, I'm hoping all these slides will be available to you because I have a bunch of websites, but we'll definitely distribute them. But you need to go to this website. You need to learn how to put on an N95. You need to actually learn how to wash your hands as a healthcare worker. Washing and gelling your hands is actually a procedure that I never see hardly anybody do correctly. So we as healthcare providers need to do our part too. We need to understand how to be safe in order to protect each other, protect our families, to protect our patients. Okay, end of aerosol versus droplet. Crisis standards of care. Like I said, there actually is a draft of an EMS crisis standards of care plan, and I'm not going to go into it. It would take forever for me to go into it. I would take another whole half-day conference. I just want to thank everybody in the EMS world who has been working on this, MPDs, leaders, frontline EMS providers. It's been an incredible journey to get this put together, and I'm excited that it's in its final draft form, and we hope to review this at our DMAC and DCAC meetings and really kind of get it out to you with more information. I hope that we can do another webinar like this, and I'd be happy to go into more detail about it. All right, so in the last few minutes that I have, I'm going to talk about pediatrics and COVID. Pediatrics and COVID, when you kind of just look at the disease process itself, you know, as scientists and clinicians, we love the science behind disease. I wish I could talk about remdesivir in kids and Decadron in kids and, you know, do we prone them? Do we not prone them? What's the IL-6? What's the, you know, the cytokine storm? You know, kids are not seeing hardly any of that. The incidence of disease in children is very low, which we can all be very, very thankful for, I think. We do have this Miss C syndrome. that has been described, the multisystem inflammatory syndrome in children, but it's extremely, extremely rare. Throughout the US, there's really been only a total of 570 cases. It looks a lot like Kawasaki's. It's occurring in older kids. It can be quite severe. There's lots of treatments now for it, and kids are surviving it. But it's not a huge part. It's not like, as frontline EMS providers, I'm not sure that that should be the first thing you think about. You may never see a case of MIS-C at all in children. I know that there have been cases in Washington State. I know they've been some of them have been quite severe. So it is something to keep in the back of your mind, but it's something that's very, very rare. There certainly are children that are asymptomatic carriers, and we all know about the asymptomatic carriers. And I put an asterisk by this because you have to be very, very careful when you're reviewing literature about asymptomatic carriers. There are many, many studies out there that are very misleading about asymptomatic carriers. We know they do exist. I'm not denying that they exist at all. But what are we taught when we go to med school and EMT school and paramedic school when we look at the literature? What section of the literature should we be paying most attention to? It's the most boring part of the whole paper. It's the methodology. It's the methodology section. That is the most important part. When you review any scientific literature, go to the methodology section, right? I do this too, I just kind of flip through the conclusion. Okay, does the conclusion, is the object and the conclusion, is it anything that has to do with what I want to know with? Object, conclusion, yeah. So that's a lot of what we do. But if you look, so you screen, you go, okay, objective, conclusion, something I'm interested. The next thing you should go to is methodology, because you want to know that the methodology actually supports the conclusion that you're looking at, okay? And some of these papers about asymptomatic individuals, they don't follow the patients long enough to know if they were just pre-symptomatic, not asymptomatic. You can't just take a cohort of patients and say, okay, your test is negative, you may have infected this many people, we followed you for 4 days. That makes no sense at all. You can't call that group asymptomatic. You can you have to follow them for several weeks to see if they come up with symptoms. And some of these people that they're studying could be pre-symptomatic. So that's my little soapbox about asymptomatic versus pre-symptomatic. But we do know asymptomatic carriers exist. We know that children sometimes are asymptomatic, although I wonder sometimes, every kid has a snotty nose, especially coming up in the winter. So it's hard to know what asymptomatic means in children, but it does happen. The thing that I really want to point out to, and the thing that you are going to be seeing as frontline providers, and this is the disease that children are suffering from COVID. There's been a significant rise in social distress related to COVID. There's been documented significant rise in alcohol-related emergencies, drug overdoses, and mental health fallout from this. There's a website link here that if you're interested, you should look at. DOH website is doing a weekly mental health sit-rep report. And it's showing these trends. The number of ED visits for drug overdose and alcohol-related, so the dark blue line here is 2020. This was last year, significantly increased, okay? Domestic violence offenses. Orange line, 2020. Blue line, 2019. Increased, okay? And I'm not saying that children are involved in this, but children are in the middle of this milieu. Children are in the middle of this milieu, and they're already quite fragile, okay? So I want you to think about even your own families. The stress of working, the stress of losing your job, the stress of homeschooling, the stress of maybe not having the infrastructure you need at home to support your children is just creating a huge toll. And if you look at, and this has actually been studied significantly, is the reactions to a disaster, the behavioral health reactions to a disaster can be predicted, actually. So here's the impact of the disaster right here. And the first phase, we're all rah, 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 we can do this. You know, after every earthquake, after every disaster, our mental psyche is like, let's do this. We're all together and we're feeling good, okay? But soon afterwards, within about 6 months or so, we see this steady decline, okay? And I love how they call this in the mental health world. This is the disillusionment era. We are in the middle of the disillusionment era, okay? And we have to brace ourselves for these trigger events. Fall is going to be a trigger event. We're going to see increasing cases. What happens in this phase is we're exhausted. I can't imagine that anyone that is viewing this is not in a slight bit of level of total exhaustion, mental health exhaustion. And, you know, work is hard. Going to see patients these days is hard. How hard is it to think about putting on your PPE every time you answer a call for EMS agencies? It's difficult. How much time do you worry about, you know, taking this infection home to your family? It's huge. It's huge. So we are all in this fatigue. Can't we get this over with kind of thing? And we have to recognize that. We have to recognize it and, I don't know, not embrace it, but just recognize it for what it is. And knowing that children around our state, around our country, around the globe are affected by this. I will tell you that the mental health cases in children, in Seattle Children's and Marybridge both, are, you know, on the rise. They're huge. There are people boarding in the EDs, in pediatric EDs throughout our state for mental health issues now. So that's the kind of, I think, disease that children are suffering the most for. And so I want to give you a solution, not a solution, I want to give you a toolkit for managing this. For you personally, for family and friends that you know, this is a great resource that's online at the DOH website. It's a toolbox for families to support children and families that are living, obviously, through all of this. So I would really encourage you guys to take a look at this. There are really practical solutions and tips. And, you know, hand it out. Send it out to your organizations, your groups that you're involved in. That I think it could be incredibly, incredibly helpful. Okay. All right. With that, I really want to encourage people that we have the way to curb this disease. We have the way to really try and make the fall not as bad as everybody is imagining. I certainly am bracing myself for the fall surge, but I think we can also feel reassured that we have the techniques that we need to keep ourselves safe. And so as EMS providers, I just want to thank you all for what you do. It's incredibly, I can't imagine how stressful it is from your perspective that we talk about, you know, ED physicians, us as ED physicians being frontline. Well, that means that, I don't know how much more frontline you can get than being an EMS provider. So thank you all for what you're doing, and just be safe out there. Do we have a question?
We do, Doc. One question from online. Question is, does she have data/advice on the effectiveness of gowns?
The effectiveness, oh, very good. The whole gown thing, you know, the whole contact precaution stuff is gowns and gloves, all right? The mask is really for, you know, obviously the aerosolized versus droplet, okay? So as I have mentioned many times before to my colleagues, the most important surface actually that you need to be very concerned about is this surface. These surfaces, these 10 fingers in hand. Gowns are protective, yes, but the way you get this disease is by, it needs a point of entry. It needs a point of entry, okay? So I'm hoping the point of entry is not really from the neck down. The point of entry is mouth, nose, eyes, okay? So this is a surface you need to be concerned about. You need to keep this clean and away from your face. So that would be my answer to that. Any other questions that came in? All right, guys. thank you very much. Signing off. Be safe out there.
And with that, we'll take a 10-minute break.
I'm like, I'm gonna get everybody in here. He's gonna like,
tied up and naked.
I know, totally. And I have low blood pressure.
Recess
too,
two.
and I crack my chest. No, don't do it.
You're gonna leave me in recess 1.
Yeah. There's gonna be a resident doing my intubation. God damn it.
3 chest tubes.
Totally. Is there like a
we're live. We're streaming.
Thank you, Dr. Sakata. That was fantastic. Our next speaker will be Dr. Mike Long. Mike comes from San Francisco. He did his pediatric emergency medicine training at UCSD in San Diego, and he's been with us at Mary Bridge for the past 3 years. He is going to be speaking today about pediatric sepsis. Mike?
Thanks. So, I'm going to be talking about sepsis and kind of what we are thinking with regards to this level of infection and how we want to include you folks in kind of the immediate bundle of care that these patients need. Any recommendations I make may be different from what your protocols are, so of course, if in doubt, defer to those or your medical controller. Today I want to be able to start by defining sepsis for y'all. And then we're going to, in that, we'll position position you guys as pre-hospital providers in that role of recognizing and then initiating the early critical interventions that these patients need. So big picture in sepsis, our goals, you can't treat it if you can't recognize it. So we want to recognize which patients are septic and going into septic shock. We want to initiate their resuscitation. In that, we want to obtain blood cultures on them, get antibiotics on board, reassess our therapy and adapt our responses to that. And then ultimately, we want to identify where the infection is coming from, get control of that site, and then we want to peel back and get that patient back to normal. Where you guys as first responders are going to be essential to that is helping us in the recognition of these patients and initiating that early resuscitation in most situations. If you're ever involved in an interfacility transport, you may be helping us with the later steps later in the patient's care. So how we define sepsis. Sepsis is really a subset of infected patients, really infection of many etiologies. And so we see tons of infected patients all the time who are otherwise well, and they do better without needing aggressive interventions. The septic patients are going to be a subset of those where they have really signs of end organ dysfunction as a result of an inappropriate immune response to that infection. And then a subset of those patients even further are those who are in septic shock, wherein the organ systems that are involved are their cardiovascular system, and those are the patients that are really actively crumping for you. So we want to think about patients who are at risk for sepsis. This is not an exhaustive list, but are probably most frequent flyers for this scenario. Neonates do not have the robust immune system that older patients might have, and so really any infant under the age of about 6 to 8 weeks is really at risk, in particular those who may be premature infants. Patients who have indwelling hardware, so in particular central venous lines. Some of our oncology patients, for example, may go home with indwelling ports or catheters. Those can easily get infected. Some patients have hardware, spinal hardware, pumps, things like that. All of those sites can become sources. We worry about it in any patients who are immune compromised. There are congenital immune compromises as well as iatrogenic immune compromises where we create it by medications or treatments the patients may have received. And then, somewhat bridging from the immune compromised population, we think about it in our chronic illness patients. So patients with cancer, patients who don't have spleens like in sickle cell disease or in other blood dyscrasias, transplanted patients, patients with autoimmune disease, patients with prior sepsis. Those patients are not normal hosts, and so something about them made them predisposed to sepsis. But really, at the end of the day, anyone can become septic, and if it crosses our mind, we need to be darn certain it's not there based on our evaluation. So when I walk up on a patient and I'm worried about shock, the things I'm thinking about in my first seconds of contact with a patient are, what do they look like? What's their mentation? Is it appropriate for the situation? Or are they too listless for me? Are they excessively agitated without a clear trigger for that? Are they breathing comfortably? What's their color like? What's their perfusion? If there's a strike against them in any one of these three regards, my heckles go up and I'm extra cautious with them. When we have those signs of shock in the setting of fever or hypothermia that's not otherwise explained, those patients are under watch. So when we think about sepsis, we talked about signs of end organ dysfunction. This is not an exhaustive list at all, and I'm not going to read through them at this time, but when things start to go haywire, we want to ask ourselves why. So once we have those signs of end organ dysfunction, and then we involve the cardiovascular system, then we're getting into the realm of septic shock. I'm always checking these patients' perfusion. I'm feeling their distal skin. I'm checking their pulses. I want nice, strong pulses, but not too strong. I don't want thready pulses. I want them just right. Patients in septic shock can be vasodilated or vasoconstricted. So we think of this as warm shock or cold shock, respectively. Early on in septic shock, patients may be dilated. Those patients are flushed. They have flash refill. They have bounding pulses. Vasoconstriction is going to be more of a compensatory mechanism that's really designed to shunt blood to the core to maintain that critical end organ perfusion. We think about this in those pale patients, the mottled ones, the ones with delayed refill. They're weak pulses, and they feel cold distally. So who's on the cusp of either one of those? That's where I'm paying attention to heart rate. Unexplained tachycardia is always an early clue to sepsis, especially if it's disproportionate to a fever that the patient might have. So in sepsis, you can get direct depression of the myocardium as well, and that's going to contribute to weak cardiac output, a hypoperfused state with acidosis, etc. Kids are going to compensate extraordinarily well to this kind of insult, and so hypotension in them could be a very late finding. Ultimately, it's that cardiovascular failure that's going to exacerbate every other organ dysfunction. So by the time you're in septic shock, these patients are really falling off the cliff for you. So our goal in recognizing and treating sepsis is to get early goal-directed therapy for these patients. This can be really subtle, and so if you're in doubt, presume sepsis, we can always peel off in our treatment course. And again, if you're on the radio with us, we can help guide you in those decision makings. You know, I'm never going to be hesitant. You know, I'm never going to have any second thought about you know, if you bring somebody in and you put them on oxygen and give them an IV and fluid, even if it's unnecessary, you know, your actions are in the right place, and we can always peel that off. That's not a big deal. So when we recognize a patient as being septic or in septic shock, we start a clock on their treatment, and we know that timely treatment in these patients will optimize their outcome. So in the patients who are in septic shock, our goal is to get definitive treatment on them and try to normalize their perfusion within an hour of patient contact. We have a little bit more leeway if they're not in full-blown septic shock, but still, even then, there's a clock that's started. And we'll go through these priorities on the bottom of the slide here in the next few. But these patients all need good access as early as we can. We want to get blood cultures if possible. We want to get antibiotics on board. We want to monitor them clinically and then from a laboratory perspective for signs of end organ perfusion. And then we're going to titrate fluids and blood pressure support to normalize their vitals as best we can. So very early in the septic patient's course, we want to get IV access on them. If we can't obtain IV access in a timely fashion, we're going to proceed to intraosseous access. You know, if you're on the cusp of a patient you're worried about and they're not clearly in septic shock, we can discuss their access over the radio. You know, this might be somebody where it's acceptable to monitor them closely, get them in, and we see them within 10 minutes and decide and go from there. But let's have that conversation. In terms of fluid that we're going to be giving them, we're going to get them early crystalloid fluid, about 20 cc's per kilo over 5 to 10 minutes. If they have known underlying cardiac disease, we want to be more cautious and give them less. If we're worried about impending cardiac failure, you can always give less fluid and then give more later as they tolerate it. When I'm giving these patients fluid, I'm always monitoring what their response to it is. I want to make sure that they're tolerating whatever we give. Feeling the pediatric patient's liver is really a clue to monitoring what their heart is doing with the fluid. If I'm starting to feel a liver edge, I back off on giving fluid immediately. That can be an early sign before we get into full-blown pulmonary edema. And then we're going to, you know, once they get to us, we're going to continue their fluid boluses until their perfusion normalizes. If they're not tolerating fluid, then we're going to move on to pressor support. Probably their best indicator of restored perfusion is probably urine output. And so we're going to be monitoring that very closely. So if a patient's en route is voiding for you as they're giving fluid, that's a great sign for us. We're going to give supportive oxygenation. Nasal cannula face mask is usually fine, but we can always escalate support with some form of positive pressure like high flow or CPAP. In the patients who are really crashing, intubation for them will improve their cardiac mechanics. Ideally, before I intubate the septic patient, I'm going to try and make every effort to resuscitate them and get them as stable as I can. So I've talked before about getting early antibiotics on board within an hour of them presenting. Obviously, in many of our first response situations, that's not going to be within the scope of your care, but that's our goal when they get to us. We focus our antibiotics broadly to target their patient's most likely infectious source. That may come down to their history, their predisposing risk factors. Maybe we have information on them on recent infection or recent cultures, or what their individual risk factors are. So I talked before about, we're going to keep giving fluid as long as the patient will tolerate it. If they're not tolerant, we're going to move on to giving vasoactive drips. For patients who are in cold shock, in that case, we want to target primarily inotropic support, and so in them, we're going to use epi. In patients who are warm, they've got pretty good cardiac function still, but we want to create some vasoconstriction. And so for that, we'll use norepinephrine because it's more peripherally active. And then based on their response, we may add other drips. So sepsis is a hypermetabolic state. So these patients need regular glucose checks. If there's hypoglycemia, we're going to correct that very aggressively. We might tolerate some mild hyperglycemia in these patients. Hyperglycemia on initial labs can be a sign of their systemic stress as well. So they can get any number of electrolyte abnormalities. Our goal will be to normalize them. If they're anemic, we will tend to support anemia under hemoglobin of 10. And there's likely a role for steroids within sepsis from the perspective that sepsis is an autoimmune disorganized state, an inappropriate autoimmune response. So traditionally, we've used steroids when blood pressure support is inadequate. That's another layer of support we can give, but there's a growing body of evidence that there's a role for steroids even sooner. So we want to support the body and get the body back to normal. And so we're going to titrate all of our various therapies as we move forward in these patients' care to get towards that normal physiology. We're going to follow markers of end organ dysfunction like lactate. We're going to follow central venous oxygen saturations much later in a patient's course. More important than any lab features, though, on the septic patient is their exam. There's going to be no diagnostic test that's going to be better for us. For me, the septic patient, everything is going to come back to what's their mentation, what's their breathing, what's their circulation. If we're improving in those regards, I'm less worried about what the labs are going to show. And you may have a patient that may be improving with whatever you can do in the pre-hospital scene. It's really important for us to know that the patient is looking better as they're getting fluid, for example. So to recap, I approach sepsis like it's an inappropriate immune response to an infection. And in that, you're going to get life-threatening end organ dysfunction. As first responders, you're integral to our initial recognition and getting out of the gates in terms of our early goal-directed therapy on these patients. Septic patients are extraordinarily dynamic, and they need constant reassessment and support throughout their care. So I think that's it. Any questions?
So, Doc, just a quick question. You discussed the palpation of an enlarged liver, and I just wanted to touch on that briefly. Do you feel that for providers in the field, do you feel that's an effective tool that we could learn or should learn for our evaluation of our peds?
I do. I can't think of in nearly every case I see where I have a patient who's infected, part of my routine exam is feeling the patient's right upper quadrant. If I can't feel a liver or can't percuss a liver, I'm feeling pretty good, but it always catches my eye when I can feel that. I think it's easy to do, and it's part of my rapid assessment on nearly all those patients. So if anybody brings their patient in and they want a chance to learn about how to feel a liver, let's do it. It's easy and quick, and patients tolerate it really well. So awesome. My routine circulation check is, look at the patient's color, feel the liver, check a fem pulse, put my hand on their foot, is their foot warm, And that tells me a ton out of the gates. And if you go on rounds with a pediatric intensivist in the ICU, they're doing the exact same thing.
Great. Additionally, I have a question from online. The question is, with the Zoll X series monitor, we can monitor hemoglobin. How important is it for us to monitor these numbers versus recording a baseline for the ER physician?
I'm not familiar with that function. By recording a hemoglobin, do you mean you're recording a pulse ox, or what is it you're measuring? Does it give you a hemoglobin value? Do you know, Lila? No?
I'm not familiar with the Zoll X series. I'm not in
I'm
that
not.
feature.
I'm not sure, to be frank. I'm not sure, to be frank. I'm not going to be inclined to take a calculated hemoglobin value off a device because I'm going to be able to get that lab result really quickly. And I'm certainly not going to decide on transfusion, et cetera, based on that number. Probably less of a priority. So.
Excellent. And one more question. Are you an advocate for lidocaine for pediatric IO for comfort?
Oh, I think it depends on your clinical situation. If you have a patient, my answer to this might be different too, based on an inpatient situation versus a patient who's on the floor in their home, right? If I have a patient and we're really struggling to find IV access, and I really need IV access, but the patient has great mental status still, and I know it's going to really agitate them or potentially be pretty miserable to get the IO, I use lidocaine. It takes seconds to do, and I've had patients not even wince getting the IO in that case, right? That said, if their mental status is crap, they're not feeling it, and I got to move on, so I place the IO. Now, if you're in a position where you have a patient whose mental status is great, you think they might be septic, you can't get an IV on them, I would come back to, do we have to delay that patient's transport to get that IO? Or can we talk and perhaps you're stable enough that we could come in and one of our nurses could grab a line? You know? And so I think if you're in that position in the field where, you know, by all measures we look okay, let's have that discussion. But if they're hypotensive and somehow have good mental status and we can't get a line, let's do it, you know. Can't hurt. So.
All right, that concludes our questions. Let's take a 10-minute break. Thank you.
Thanks. All right. Thank you.
Thank you, Dr. Long. That was a great presentation of sepsis. There was one question that came in after we had closed the question and answer period. I just want to quickly address that. The question was about what should you do for fluid management in a patient who has underlying kidney failure, kidney problems. So if a family is telling you that their child has kidney dysfunction or kidney failure, you may have to be a little bit more cognizant of the fluid rapidity at which you're giving. So for patients who have known heart failure, known kidney failure, who you are giving fluids to and you are concerned a little bit about overloading their system, what I do, and it's very easy to do, is just start with half of the amount of fluids that I would give. So instead of an initial 20 per kilo bolus, I start with 10 per kilo, I push that in rapidly, and I do frequent reassessment. So I listen to their lungs. Are they now crackly or are they clear? Do they, is their liver still where it was when I first examined them? Great, I'm gonna give that other 10 per kilo. And that way you are able to tell how the patient is managing their fluids. For sure, perfusion to the end organs in the brain take precedence over fluid overload for the kidneys. But what you don't want to have happen is you push a whole bunch of fluids into a patient who can't tolerate it, and now you're en route to the hospital and you need to manage their airway and their respiratory failure, which you have precipitated by aggressively giving fluids without careful reassessment. So 10 per kilo in these somewhat tenuous patients, and then just repeat it. You can always repeat your interventions, harder to peel off when you're in the rig en route. And if you have any further questions about this, please either send an email, either to me directly or to Wes, or however these emails are coming through.
Send to anyone in our EMS division.
Great, anybody in the EMS division. Okay, our next speaker, I'm very happy to introduce Dr. Andrea Gravatt. She hails from Pennsylvania. She did her pediatric training at Duke University, and she is one of our most senior physicians in the emergency department. She's been with Mary Bridge for 19 years. Dr. Gravatt is going to speak today about anaphylaxis. Dr. Gravatt, welcome.
Thank you. I just wanted to thank all of you first responders for doing such an amazing job in keeping the community healthy, and also wanted to thank Lila for putting this amazing program on, and thank you for giving me the opportunity to present. So I've entitled my talk this morning to be The Boys and the Bees, A Tale of Anaphylaxis. I have no disclosures. So over the course of the next 30 minutes, I'm going to be discussing anaphylaxis with respect to a case study, and then we will define anaphylaxis and the criteria that are needed to meet that diagnosis. And then we'll move on to see what does anaphylaxis look like at the cellular level, what does it look like at the clinical level, and then we'll move on to the treatment of anaphylaxis, and then I'll close with some final teaching points. So our case study is of two 6-year-old boys. They're twins. One is named Austin and one is named Mason. Austin was twin A. He was always on time. He did everything according to the rules. He always paid attention. And Mason, who was twin B, was always late. He never paid attention to the rules, and he was an instigator. So they were bored during COVID times, and Mason had a wonderful idea of wanting to whack the beehive in the back of their yard with his bat to see how many bees actually lived in the hive. Austin didn't think it was a very good idea, so he left the scene and began to walk home. And Mason took his bat and whacked the hive. Now he was immediately stung on his back 12 times by the bees, and Austin, who was about to reach his house, was stung only once on the arm. When he got to the house, he began to feel a little bit dizzy. He didn't feel really well. His stomach was starting to hurt. He had a hive on his arm where he was stung, and he felt a little bit dizzy and had his throat act funny, and he complained of a little bit of difficulty breathing. Now Mason, on the other hand, had the 12 bites to his back, and he developed hives on his back, but he was out running around and catching the bees in the jar. When Mom looked at him, she immediately saw what was happening, so gave Austin Benadryl, which he promptly vomited. Then she noticed that he began to look flushed, his lips were swelling, so she became concerned and she called 911. EMS arrived at the scene and they saw that Mason was running around catching bees in the jar and he had diffuse hives to his back, but Austin, who had one hive on his arm, was lying on the ground not looking well. He had facial edema, he was flushed, he had some difficulty breathing, and he had vomited again. He was dizzy. His vitals were notable for a blood pressure of 72/60, low, pulse of 154, high, respiratory rate of 27, high, O2 sat of 94%, low, and when they listened to his chest, he had mild expiratory wheezes. So we'll continue this case study in just a few minutes. The teaching point here is that the extent of the exposure does not always correlate with the severity of the symptoms. Now, the international consensus on anaphylaxis loosely described anaphylaxis as being a serious, generalized or systemic, allergic or hypersensitivity reaction that can be life-threatening or fatal. Now, that's a great definition. However, another committee comprised of allergists, immunologists, and other experts defined the criteria for anaphylaxis that was more helpful for those of us who were first responders, for those of us who were caring for the individuals that had anaphylaxis, to know what the criteria were to meet the diagnosis and what we needed to do to treat it. So they came up with 3 criteria, of which you only needed one of the 3 to make the diagnosis of anaphylaxis. And that criteria, you only needed to have one to meet it. And the first was, after the acute onset of an exposure, within minutes to hours, there would be involvement of the skin, mucosal tissue, or both, so that the individual would have hives, a pruritic rash, flushing, swollen lips, swollen tongue or uvula, and or respiratory compromise manifested by difficulty breathing, dyspnea, wheezes, stridor, hypoxia, and or hypotension or end organ malperfusion manifested by hypotonia and collapse, syncope, or incontinence of bowel or bladder. That's the first criteria. The second criteria is not that different from the first criteria, but they allowed for the ability to make the diagnosis of anaphylaxis without having skin involvement. So the criteria is to have 2 or more of the following: skin or mucosal tissue or both, respiratory compromise, hypotension or end organ malperfusion, and now they added GI symptoms: abdominal pain, vomiting, or cramping. Now, the third criteria was that after an exposure to a known allergen, there would be a drop in the systolic blood pressure. So in an adult, it would be offset by 30% from baseline, or less than 90 millimeters of mercury. In small children, infants, less than 70. In the age group between 1 to 10, 70, plus 2 times the age in years, and in the teenager, less than 90. So most of the time, the skin is involved. In fact, almost 90% of the time, you'll have hives or a pruritic rash of some sort, flushing, mucosal swelling may be involved, tongue, uvula, or lips. And almost to that degree, the airway is involved with hoarse voice, stridor, chest pain, wheezing. And about half the time, the GI tract is involved, as well as the cardiovascular system, again with vomiting, abdominal pain, diarrhea, and then in cardiovascular system, chest pain, tachycardia, hypotension, or syncope. And then we have CNS involvement that occurs about 10% of the time, manifested by headaches, dizziness, confusion, or anxiety. Now, the triggers for anaphylaxis are many, and most commonly are the flying insects such as bees, hornets, and wasps. And then there are bites, especially from reptiles such as snakes. Commonly foods, particularly peanuts, tree nuts, eggs, shrimp, wheat, can cause anaphylaxis, or food additives such as MSG, monosodium glutamate. Medicines, with penicillin being a really common one, can cause anaphylaxis, and in and out of the hospital, latex, NSAIDs, in the OR, neuromuscular blocking agents. Vaccines can trigger anaphylaxis, and environmental products such as hay or pollen or grasses, and the physical environment such as cold that can induce hives, and radio contrast media. The thing about it, though, is a lot of times an individual will have anaphylaxis and we don't have a clue as to what triggered it. Now, going back to our friend Austin, he met the criteria for the definition of anaphylaxis because he had skin and mucosal involvement. He had hives the rash was peritic, he was flushed, he had lip swelling, he had respiratory symptoms because he was wheezing, he had complained of chest pain. He had GI involvement as he was vomiting, and of course he was dizzy. When we look at his vital signs, we notice that his blood pressure was off from where it should be. 70 plus 2 times the age in years should give him a systolic of 82. His blood pressure was 72/60. He met the criteria for hypotension. He was in anaphylactic hypotensive shock. So now let's see what's going on with anaphylaxis at the cellular level, and I will tell you it's very interesting and it's quite complex. The key players in anaphylaxis are the mast cell and the IgE antibody. The mast cell is a type of white cell. It is full of granules, and these granules are full of chemical mediators. The IgE antibody is one of several types of antibody and tends to be elevated in those individuals that have atopic disease, but it is present in everyone. The way that it works is that the allergen enters the circulation and it is taken up by an antigen-presenting cell, and that antigen-presenting cell meets the B cell, and with the help of a T cell helper cell is activated and becomes a plasma cell. The plasma cell secretes IgE or releases IgE into the circulation, and IgE travels everywhere. It goes around the circulation to the body and looks for receptor sites, which happen to be many of them on mast cells, basophils, and neutrophils. The receptor is an Fc receptor that they have a high affinity for. These Fc receptors are all over the mast cell. And what happens is they click onto the receptor and hang out until another antigen bridges two IgEs that are attached to the mast cell, which triggers a series of pathways in the mast cell, causing the granules to be released, and all of the chemical mediators are now released into the circulation to go everywhere. And below you can see an electron microscope picture of a resting mast cell, and then what it looks like once it's activated and in the process of releasing all of those mediators. So then we have all these mediators traveling around the circulation and causing damage. Histamine is one of the mediators that happens to have its effect by causing vasodilation and increased vascular permeability. And what happens here is that the individual becomes flushed from the vasodilation, and then they have fluid shift because of the increased vascular permeability, which permits intracellular fluid to go into the extracellular space causing edema, and an effect of hypotension and hypovolemia, which will reflect as tachycardia and hypotension on the vitals. Prostaglandin has its effect on smooth muscle. It causes bronchoconstriction, coronary artery constriction, and also acts with the smooth muscle in the GI system, causing constriction and GI pain. Leukotrienes act very similarly to histamine, causing vasodilation and increased vascular permeability. Proteases, such as tryptase, causes bronchoconstriction. And then we have proteoglycans and platelet activating factor, which trigger DIC and involve themselves with platelet aggregation and cause inflammation. Now, IgE is not the only player here. We also have IgG, which is another immunoglobulin, and it happens to have affinity to basophils, neutrophils, and monocytes, which are other types of white cells, and also have granules and also can release these chemical mediators into the circulation much in the same way as the IgE response. We also can trigger anaphylaxis by the activation of the complement cascade. Now, when complement is triggered, it can break into pieces, and C3, C4, C5, which are part of the complement cascade, are called anaphylatoxins. These anaphylatoxins are very potent inflammatory mediators, and they also cause capillary leakage and bronchoconstriction. These anaphylatoxins themselves can trigger mast cells and basophils. So you can see that anaphylaxis can be triggered not just by IgE, but also by IgG and activation of the complement cascade. So what we know now is that these chemical mediators traveling throughout the body indeed make anaphylaxis a multi-system disease problem. Upper airway involvement, lower airway involvement, digestive system involvement, cardiovascular system involvement, involvement of the skin, and of course, involvement of the head. So what does this look like clinically? Well, it looks like hives, a pruritic rash that's flushed, or diffuse and extensive flushing. It looks like swelling of the lip, swelling of the tongue, swelling of the uvula, making any attempt for intubation challenging. It looks like swelling from the intravascular space. The fluid travels to the extravascular space, causing edema on the face or anywhere on the body. It looks like difficulty breathing with wheezing and difficulty swallowing, and it looks like vomiting and abdominal pain. It looks like syncope. So the timeline for anaphylaxis is a fast one. It can be triggered within seconds to minutes and rarely can go to hours. The course is unpredictable, and in some cases, because of the endogenous production of compensatory mediators within a person, it can resolve without intervention. A lot of this has to do with the genetic component of the individual, but for the most part, it's a severe reaction and often results in death, particularly if it's the iatrogenic causes, such as the infusion of penicillin in an individual with a known penicillin allergy, where death can occur within 5 minutes. It can occur very quickly with stinging insects, flying insects, food within 30 minutes, such as in peanut ingestion. Now, there is an occasion where anaphylaxis is treated, and then it recurs about 12 to 72 hours after the resolution of the symptoms. This is called biphasic anaphylaxis. This happens when there is a recurrence of symptoms after the resolution of the initial episode, and about 50% of the time it requires treatment. A clue would be if the person presents with wide pulse pressure. Now, the individuals who have asthma, cardiovascular disease, respiratory disease such as COPD or recurrent pneumonias, or those types of comorbidities, have a tough time doing well with anaphylaxis. If the inflammatory processes are already triggered from some other infection, those individuals are also going to have a tough time resolving their anaphylactic episode. And those individuals who are on medications such as beta blockers, ACE inhibitors, or alpha adrenergic blockers have medicine on board that is going to interfere with the management that we have to treat anaphylaxis. So the teaching points here is to recognize anaphylaxis in its early stages, keeping in mind that not all anaphylaxis presents with hives or some sort of skin process. And those individuals who have asthma and are wheezing does not necessarily mean that they are simply having an asthma exacerbation, but in actuality may be having an anaphylactic reaction, and their wheezing is not simply an asthma exacerbation. So now let's move on to treatment. It is very well documented that the initial treatment for anaphylaxis looks like this. The first thing is to remove the instigating cause. If the individual is having an anaphylactic reaction and penicillin was just pushed and the individual has a known allergy to penicillin that was not recognized, it behooves whoever's caring for this person to stop the penicillin. If the child is eating peanuts and is known to have a peanut allergy, take the bag of peanuts away from the child. And then we move on to airway, breathing, and circulation. Then the next treatment line is epinephrine. It's epinephrine IM injection. The universally accepted first-line drug therapy for anaphylaxis is epinephrine IM. And there's a reason for that. Epinephrine has its mechanism of action at the alpha-1, beta-1, and beta-2 receptor sites. The alpha-1 receptor site has its effect by causing vasoconstriction and increased peripheral vascular resistance. So with the vasoconstriction and peripheral vascular resistance being increased, there is a reduction in hypotension and shock. There's also a decrease in mucosal and airway edema. Epinephrine also has its effect at the beta-1 and beta-2 receptor sites, and its adrenergic effects have to deal with increased ionotropy, the contractility, and chronotropy, the heart rate. At the beta-2 site, it works as increasing bronchodilation by relaxing smooth muscle, not just in the pulmonary system, but also in the cardiovascular system and also the GI system. And more importantly, it also acts by decreasing the release of mast cell granules. So between those effects, epinephrine is the perfect drug for anaphylaxis. Now, the quickest way to administer epinephrine is IM and with an auto jet injector. This is because it's rapid, it's introduced into the muscle belly of the mid-outer lateral thigh, and it's preferred over sub-Q or IV because it has a rapid rise in plasma levels, which taper off over 1 to 2 hours. You can repeat this IM epinephrine every 5 to 15 minutes for an effect, and this is necessary in about a third of the cases. We don't prefer sub-Q any longer because of the absorption problem, And the issues with IV is that there are many opportunities for dosing errors, and also there are a lot of drug complications when epinephrine is given IV. When obtaining epinephrine from the vial, the concentration is 1 to 1,000. The dosage is 0.01 milligrams per kilo with a max dose of 0.5 milligrams. In the larger individual, greater than 50 kilos, the dose is 0.5 milligrams. Now, the auto-injector doesn't come in all of the millions of different weights. It comes in 3 forms: 0.1 milligrams, 0.15 milligrams, 0.3 milligrams, and this is offered by numerous manufacturers. So what we see here is the auto injectors. You see that there are many different forms, but they're all pretty much the same in that once you release the safety click, you are able to inject the medication, and it is injected through the needle into the muscle through the clothes. Now, those individuals who are requiring multiple doses of epinephrine to break their anaphylactic shock or anaphylaxis tend to have a higher risk for biphasic recurrence. Now, some facts about epinephrine is that if you have an infant that is 7.5 kilos, for instance, they can actually tolerate the auto-injector. The studies show that infants are able to have a high tolerance to the higher doses if the infant is otherwise healthy. To avoid from hitting the bone, pull the muscle belly up and then inject the auto-injector. The other thing about epinephrine is if it's expired on the box, that you can still use it for up to 4 months, and frankly, if that's the only thing you have, you can use it no matter how long it's been expired. But from the wilderness medicine conferences that we go to, the autojet injector always has some residual medicine inside it, and you can draw it up and give it as an extra ability to have extra epinephrine. The prescribers and providers who write prescriptions for epinephrine should always dispense more than just 1 EpiPen because of the biphasic response or potentially the need for epinephrine more than 1 time. Again, for those individuals who have refractory anaphylaxis to IM epinephrine, there is a role for IV epinephrine, but no role really in the field at this point in time, again, due to dosing errors and the complications of epinephrine. So, there are many, many studies that look at the delay or the lack of administration of epinephrine and what happens to those individuals. And as you can probably guess, if epinephrine is delayed in its administration, those individuals have poorer outcomes and higher risk for fatality. They also are more likely needing to have additional doses of epinephrine because the granules have a higher chance to continue to break open and travel throughout the system to release all of the mediators, and the mediators have a longer time to have its effect on the body. Those individuals that have delayed administration of epinephrine have longer ED stays and are more likely to be hospitalized. They also have an increased risk for this biphasic reaction. So once we moved on to the epinephrine administration, then we moved to oxygen and the administration of IV fluids, either IV or have to be administered IO if IV access is not able to be obtained. The fluid that we use is normal saline, and the position that the patient is placed in is Trendelenburg with elevated legs, unless the patient is a pregnant woman. Now, the massive fluid shifts that we see in anaphylaxis, again, is due to these mediators that cause vascular permeability and vasodilation. This vascular permeability at times can result in intravascular fluid moving to the extravascular space quite quickly. In fact, 30% of this extravascular volume can move, causing hypotension and tachycardia. Now, sometimes that movement in and of itself causes the release of endogenous catecholamines that can blunt the response to anaphylaxis. So again, the fluid that we recommend is normal saline bolus of 20 cc's per kilo and the ability to re-bolus after reassessment. The bolus is not a 60-minute infusion. It is a rapid bolus of 5, 10, 15 minutes, and in a larger child, the bolus would be a liter. Now, there are additional drugs that can be used in the treatment of anaphylaxis: antihistamines, steroids, and bronchodilators. Now, antihistamines respond at the histamine receptor site. They block the H1 receptor, such as a drug called diphenhydramine, hydroxyzine, or cetirizine. This block at the H1 receptor will help to relieve the itching and hives, and it also improves upper airway respiratory symptoms. But it does not replace the use of epinephrine. It does not relieve lower airway obstruction, and it does not inhibit the release of chemical mediators from mast cells. Now, another histamine receptor is the H2 receptor, and we have agents that block at that site called famotidine, which also helps to relieve itching and hives. However, it does not replace epinephrine. It does not relieve upper or lower respiratory obstruction. It does not inhibit mediator release from mast cells. Now, the data on the use of bronchodilators comes primarily from the treatment of the use of albuterol in those individuals that have asthma. So you can use albuterol as a beta-2 adrenergic agonist. However, it does not replace epinephrine. It does not prevent mucosal edema, and again, it does not prevent shock. So there's much going on with glucocorticoids. It was once felt that glucocorticoids prevented the biphasic response that we would see in anaphylaxis. However, there's data now stating that's probably not the case, and actually glucocorticoids probably have little benefit in the treatment of anaphylaxis. Furthermore, glucocorticoids do not act rapidly. They take hours to have its action. So now there's a subset of individuals with allergies. These are the children that have very severe allergic reaction to agents, such as peanuts, such as penicillin. There should be an extra low threshold for giving epinephrine to these children that are known to have very severe allergies to exposure, or children that have a disorder called mast cell disorder. These individuals have most likely have seen an allergist, and the family will know that even with mild symptoms, epinephrine should be administered. And in some cases, if there is an ingestion of a known allergen, for instance, those individuals should be treated in the absence of symptoms of anaphylaxis. So just like any disease, anaphylaxis has a differential diagnosis as well. I've listed some of the differential diagnoses, but the important thing here is that anaphylaxis proceeds quite rapidly. There's no time to cerebrate between all of the differential diagnoses. You don't want to miss the diagnosis of anaphylaxis, and you certainly do not want to miss the early window of epi administration. Now, going back to our friend Austin. Austin had the stinger removed by the EMS provider. Epinephrine was administered early, IM, as 0.5 milligrams in the auto injection, and he was already placed in the supine position because he was dizzy from the outset. An IV was placed and he received 20 cc's per kilo of normal saline rapidly, and he required 2 boluses before his blood pressure normalized. Oxygen was administered and he also got diphenhydramine. His wheezes resolved with the epinephrine, so albuterol was not needed, and they did not administer solumedrol, and he was then transported to Marybridge ED, where he was placed in observation after his initial evaluation. So the final teaching points is to recognize anaphylaxis early on and act on it. The first-line drug is epinephrine. And if you're thinking about giving epinephrine, or you're not sure if you should give epinephrine, you should just do it. Thank you.
And with no questions, thank you very much, Doctor. We'll pick back up at 11 o'clock.
Thank you, Dr. Gravatt. That was an absolutely fantastic talk on anaphylaxis. Our next speaker is my fantastic colleague, Dr. Warren. Dr. Warren is initially from Kansas and did her pediatric emergency medicine training in New York City. She has been with Mary Bridge Hospital for approximately 6 years and is going to be speaking today about pediatric airway. Dr. Warren?
Thank you. So today's subject here is pediatric airway, which is uniquely different from the adult airway and makes for a few problems in the field sometimes. So as we often do, we'll start with a case. A 3-year-old female was eating dinner with her family and she started to choke. They called 911 while attempting to clear her airway with some back patting and finger sweeps. EMS arrives right on time, panicking parents. By this time, the child is now obtunded. She has blood at her mouth. She's cyanotic. There's some inspiratory stridor, kind of quiet, but there. Paradoxical movement of her chest. And she's breathing a little less frequently than she should. So does this child need airway support? So airway support needs to be provided whenever, in any situations where there's a failure to oxygenate, failure to ventilate. Do they lack protective reflexes? Meaning, can they gag, can they cough? Do they have excessive efforts or just weak efforts, meaning they could be impending failure? So regarding the pediatric airway and how it's different from adult, there are some significant differences in many parts of the anatomy. So the tongue in the child is large. The adult is considered normal. I don't think they were considering Gene Simmons there. The epiglottis shape in the child is kind of floppy and U-shaped, whereas in the adult it's more controllable. Firm and flat. The epiglottis is found a little bit higher in the pediatric patient, and the trachea is, of course, smaller and shorter, making it a lot easier to do a right main stem intubation. So you have to be careful there. The shape is more like a funnel, and the position of the larynx is a little more posterior. It makes a little bit more of an angled approach, so rather than straight. The narrowest point in the pediatric patient is at the cricoid versus the vocal cords, so it's just below the vocal cords where it's narrowest. The lung volume, of course, you have to pay close attention to so you don't cause barotrauma. So in an infant, average total lung volume, 250 mils, but in the adult, 6,000. So they do make some different size bags, and you can have access to those. So here is our anatomy, and you can see in the child versus the adult that greater funnel shape, and where the cricoid ring is in children is the most narrow part. So there was a study done in '97 that studied, they paralyzed people and studied how long it took them to desaturate. It takes a very short time for the pediatric patient to desaturate due to they have an increased BMI. They have increased oxygen consumption, and they're often quite fearful, so that increases their oxygen consumption too. But they do start to desaturate quite quickly at about the 3-minute mark. So versus the normal adult can last, out to 6 or more minutes before they start to desaturate, which gives time. For example, this study used succinylcholine. Succinylcholine will wear off about that 6-minute mark. So. Right. The physiology of the pediatric patient is pretty important too. They're very dependent on their oxygen due to the increased vagal tone. So hypoxia leads directly to bradycardia. Bradycardia can lead to hypotension, and then hypotension just exacerbates the hypoxia. So it's a vicious cycle corrected by getting some oxygen into that kid. Kids are fun, right? They're so fun. It's really important to use a very calm approach with them, though. Scared children, they cry, they scream. This causes excess airway secretions, can cause edema of the airway, and all of that increases the airway irritability. So it doesn't take much to cause a vagal response. They also really don't understand you. They don't have a lot of language. They can't follow instructions. They're going to fight you, and all of that increases their metabolic demand for oxygen. Positioning is very important for children. You want the head forward but not extended. You need a towel roll in a position that aligns the ear with the sternal notch. The head of the bed needs to be elevated slightly, if possible, to assist the diaphragm, because the diaphragm is the major muscle that assists respiration in children. Their chest wall is very compliant, and so the diaphragm is their major muscle. If this child is still alert but drooling or choking, you want to try to keep them in their position of comfort. You know, whether they're tripoding, whether they want to lay on their side or whatever, try to keep them in their position of comfort. This helps to minimize turbulent airflow and maximize their airway patency. This is really an ideal position, but you can see how much support you have to give. The infant has this rather large posterior occiput, and so some sort of a headrest that allows that to sink in the middle, in addition to a shoulder roll. See really good alignment of the shoulder or of the forehead with the chin, and then the ear with the sternal notch. So, and you can see how it opens up the neck when they're in proper position. So it can take a lot of towels to make this happen. So you've arrived to this rather obtunded child. He's not fighting you. You position the patient correctly. You apply some oxygen. You note significant secretions mixed with some trace blood. As your partner's getting some monitors on. The heart rate is not fun. At 90, respirators are low. At 12, blood pressure was not obtained, and 79% on room air. This is not good. It's really important to suction secretions out of a child's mouth. So removing them from the mouth and nose, especially in the very young infant, because infants are obligate nose breathers. So very often an infant will be in dire straits, but you get their nose cleaned out, and all of a sudden it's a completely different child. So really important to get the secretions out. If those secretions are dried, be sure to apply some saline to loosen them and get them out. Jaw thrust method helps to move the tongue. Remember, the tongue is very large, and when a child is weak, they let the tongue kind of rest right on that airway. It can just completely occlude it. So using the jaw thrust method, you can help to move the tongue out of the airway. So you have repositioned the patient, and using the jaw thrust maneuver, you're really not getting that much better airflow. So now the history was this kid was at the dinner table and choking. They had that little bit hint of inspiratory striae. There's really consistent with the foreign body in the upper airway. So these are laryngoscopy blades. We very much appreciate the straight blades in children. These are called a Miller blade. And as you can see, they go from little tiny to all the way giant. There are standardized cards and like Brazo tapes and stuff that will tell you what size to do. The anterior position and angle of that airway is why the straight one is important. The curved one is probably not going to get you the best view of the smaller child. And also remember that the epiglottis is super floppy. So the straight blade helps you get control of that because you lift the epiglottis with it. When you are seeking a foreign body, in the older child, of course, you can do the chest thrusts and I think that word I can't say right now, and so forth. But the number one tool that you really want to use is your McGill forceps. They have those little grabby things on the end. They're a little bit serrated there, and they get a really good grip on whatever might be in there, if you can see it. They are a little bit awkward to use because they're angled, so you just have to work them around. So the goal of these angled ones is to have your hand out of your line of sight, and the little grabbers go straight in. You will achieve your view using the laryngoscope. So, exploring the airway, you are able to visualize a foreign body. You do successfully remove a piece of sausage from the airway using those McGill forceps. And you, again, provide a jaw thrust and some oxygen, but the child remains obtunded. There's some better color, a little bit less cyanotic. The paradoxical movement has diminished. However, when you remove your jaw thrust, it seems to return. Breath sounds are rather coarse but equal. The heart rate has improved with the oxygenation. Breathing has improved, able to obtain an adequate blood pressure. When you have upper airway obstruction in a rather awake, independently breathing child without facial trauma, a nasal trumpet can be the best way to keep the tongue out of the airway without providing constant jaw thrust for the whole trip in. Nasal trumpet is measured by going from the nose to the tragus, and that's about the correct size. You also want to get one that's narrow enough, though, to get through that nose. Don't want to do too much damage on the way in. So with improvement of the vital signs and color, you could probably expect some continued improvement over time. And a nasal trumpet can provide you that air passage. So you do your transport, and by the time of the ED arrival, the child is showing signs of improving mental status. If they're unconscious, if this child had remained unconscious and was not showing many signs of improvement, you need to provide bagging. And you can put an oral airway in to achieve the same result of controlling that tongue and providing you an open airway to bag through. That sizing is going from the midpoint to the of the incisors to the angle of the mandible. Using a BVM, of course, you want to pull the face into the mask and provide the correct volume for good chest rise, but no more. It's quite a bit faster in kids than it is in adults, so 20 to 30 breaths per minute. So. If you feel like you need a more stable airway and you're preparing for intratracheal intubation, make sure that you have a backup plan. That's the most important thing, I think. You'll want suction, oxygen, airway equipment. It's okay to use a cuffed at this point. Basically, about over age 1, you can start using a cuffed. Drugs, monitoring, extra people. Medications that we recommend, you want somebody, or they used to provide a vagolytic, atropine. However, the literature on that is inconsistent, so we don't routinely use that. The most important are sedative. You want the patient to be calm. If they're already obtunded, it really probably is not that big of a deal. but midazolam, fentanyl, and I'm a big fan of ketamine. Ketamine can be used as long as there's not a ruptured globe. So there used to be some concern about increased intracranial pressure, but we don't worry about that as much anymore. So, as far as paralytics, we do try to avoid using succinylcholine in children, but it can be given IM, and if you need it, that's all you've got, then you can use it at 3 to 4 per kilo IM, or 1 per kilo IV. And rocuronium is dosed at 1 to 3 mg per kilo. So these, I saw my first patient come in with one of these the other day. So we've heard of the LMAs, but not these eye gels. So I had to do some exploration of these. They're pretty fancy things. So if you're unable to achieve an intratracheal tube, or if you just need something fast and get them to where you need to take them, it's pretty fast. And these newer designs seem to do a better job at blocking that gastric pathway. You don't have to bother with inflating it. And you can actually intubate through them, and you can stick a tube down there small and get liquid substances out of the stomach. So, let's see, I think the literature states that the smaller ones are the ones that are most likely to be not properly placed, though. So practice on those little baby ones. If all else fails, or there's significant trauma, considering the foreign body is probably going to be above that tightest point in a child, so you might have a chance of placing a needle crike. On these little guys, it's kind of hard to find the cricothyroid space, but you can use just the end of your fingernail. It's usually better than using your finger like you would an adult. And you can place a IV catheter in there. Place the 3mm adapter on the catheter, and then you can bag. So I realized going through all these mechanics that I didn't address some of the more common things, so I just wanted to make sure that I addressed croup. So kids with croup have a narrowed subglottic space. If they get excited and scared, they're going to increase that airway turbulence and cause some increased respiratory distress. So we always try to allow the parents to hold them on their lap, if possible, to help decrease the fear. Some croupers are tripoding. Let them do what they need to do to be comfortable. And then you guys can use the 1 to 1,000 epinephrine and saline nebs on the way in. And the other one is just wheezing. So wheezing in the little guys is often due just to airway secretions. And so suctioning can reduce or eliminate wheezing in these kids. In the asthmatics and the known asthmatics and the other a little bit older kids, in addition to suctioning, of course, again, let their parents hold them if possible. Try to calm them and comfort them as much as you can, and then do nebulized albuterol. Now, if they're really severe, tight, asthmatic, you could consider some IM and epinephrine on the way in. And I probably talked too fast. So I guess final thoughts, just always make sure to have the parents get involved as much as can if they're a comfort. And also, after an intervention, kids kind of keep getting more hypoxic for just a little bit. So don't panic on that one. Give it a few seconds and see if it'll work. And then again, don't panic, yes, but
Great, thank you, Doc. Quick question.
Yeah.
Traditionally, we in the field will use apneic oxygenation as a tool to manage delayed sequence intubation or RSI for our adult patients, and traditionally we'll use a high flow nasal cannula at 15 liters per minute. And just anecdotally, I know within our own district we've had great success with that as a really useful tool. How do you feel about using that as a tool for our pediatric population?
For high flow nasal cannula, 2 per kilo.
Pardon me?
2 per kilo. I wouldn't just max it out. It's usually 2 per kilo is
2 liters per minute per kilogram.
Yeah.
Excellent. I have no further questions online. Double check here. Yep, no questions. Excellent. Thank you, Doc. We're
Okay.
going to take a break till 11:40.
Thank you, Dr. Warren, for that great lecture. Our next speaker is my wonderful colleague, Dr. Jeff Flaskerud. He's actually from Washington State, but did his pediatric emergency medicine training at Boston Children's in Boston, Massachusetts, and has been at Mary Bridge for 16 years. Today, he's going to be speaking to us about pediatric seizures. Jeff?
Good morning, everybody. Thank you for having me. Yeah, I'm Jeff Flaskerud. I'm a Washingtonian, and I'm excited to be able to try to help you guys to understand a little bit more about seizures in kids. One of the things I really want is, apparently you have the ability to send questions to me, so please do, because at the end, I'm planning on carving out a lot of time to be able to go over any questions you may have. And potentially I could even do it during the talk, so just fire those up and we'll get those going. Initially, I want to give a shout out to my colleague Tom Hurt, to give him credit, because a lot of this information in this talk is from his lecture that he created, and so I'm indebted to him. So my goal today is to give you a lot of practical information about how to deal with seizures in children, try to figure out what to do in the field and different techniques and different strategies to be able to make it so that things go really well for you. One of the things that's hard is that when a person's having a seizure, it gets your blood pumping, it gets you energized, and it can be very stressful sometimes because a lot of different things are going on at once. So we'll try to go through options and strategies to be successful. So we're going to try to go over a few types of pediatric seizures. We're going to break down into a subset of febrile seizures and kind of go over those quickly, decide whether those need to come in or not. And then we're going to go over several different medicine options. Things are always changing, and I'm not familiar necessarily with the up-to-date numbers of different types of meds that you may have. So one of the questions I may have for you is, as I go over some meds, if you have them or not, because it may not help you to go over every option. So I'll probably skip through a couple of the meds on here that you may not have to use. And the other thing to keep in mind in general is there's not necessarily one right answer. Okay, you can often have 2 or 3 options that will work well. So one of the things I like to do, and I recommend that you do also, is get comfortable with one medicine, know how long it's going to last, know what effects it has, know what potential complications it may have, and that way you're ready for those, and then you're able to more quickly help someone. So seizures in general is a nice definition. They're transient, they're paroxysmal, and they're involuntary. Oftentimes the consciousness is altered or potentially behavior is altered. Oftentimes the ability to breathe well is impaired, and frequently the patients are in a dangerous situation such as a bathtub or something like that, which makes it more dangerous for them. And in essence, you have some abnormal discharges of the neurons in your brain that are causing all of these issues. Some seizures are really brief, some seizures are long. The good news is kids in particular have an amazing ability to recover even if they seize for a long time, as long as their airway and other things are protected. So you can do a lot of things initially to help them, and then even bridge them to us, and then we can help get rid of the seizure, and you'll do an amazing job of keeping them from having some injuries into their brain and other things later. Status epilepticus is a term that we use for any patient that's had a seizure for greater than or equal to 30 minutes. And a seizure is a single event. Okay, epilepsy is a person who is susceptible to having recurrent seizures. And then nowadays we also say they have a seizure disorder instead of saying they have epilepsy, but that basically means the same thing. This is a tricky situation because now, I don't know if you've noticed when you drop people off in the ER for us that we have a lot of psych patients, and a subset of those patients will have pseudo-seizures. And I have to admit that I even have a difficult time trying to figure out whether a patient who has pseudo-seizures is actually having a seizure. So my recommendation for you in the field is to assume that they're actually having a seizure. Okay? That's the best assumption you can make. and then we can try to piece together things later. But it's extremely difficult sometimes to tell. But there's a few things that help us differentiate. One, pseudoseizures are often fairly long. Two, they're often conscious. Okay, and I'll go over some subsets of seizures where you're actually conscious, but the patients are looking around and conscious but having a seizure, so that's one kind of sign that makes you wonder, hey, maybe this is a pseudoseizure. Pelvic thrusting is something that patients that are having pseudoseizures often do. It's kind of interesting. And they're doing bizarre movements that don't have any, if you've seen lots of seizures, like, wait, that's kind of weird. So it's not to say it's not a seizure per se, but it's something that kind of might tip you off. And interestingly, if their eyes are closed, it may be a pseudoseizure. But that's not something that is a general absolute rule. The gold standard of trying to figure out whether they're having a seizure or pseudoseizure is to do a video EEG, which is not something you'll do in the field, but it's something we'll plan on doing eventually. So types of seizures, is kind of a quick overview. Partial seizures are focal events in the brain. If it's a simple seizure, that means that they are aware of what's going on. They're conscious. If it's complex, either their memory or awareness or consciousness is affected. Sometimes it's kind of hard to split hairs, especially when the kids are super young and they can't really articulate that. But that's kind of a nice breakdown. So again, simple partial seizures, a focal event. Oftentimes, in these cases, you can identify a specific focus of their seizure on an EEG or an MRI or something like that. And so twitching of an arm in an awake patient is an example. Complex partial seizures are partial seizures with a loss of awareness. A lot of times these patients have an aura, so they may actually realize it's about to happen, and they may sit down or prepare, to have one, or they may tell their parents about it. And a lot of these patients can then progress from to a generalized seizure with that same seizure. It might start as a partial and then go to a generalized. And these patients are very drowsy afterwards. As an aside, one of the things that's tricky sometimes is you see a patient that's drowsy, you've given them medicine, and is it the drowsiness from the seizure, or is it the drowsiness from the medicine, or are they still seizing? And there's something that we call subclinical seizures, where you can't tell for sure they're having a seizure, but they're not acting right, and a lot of times those patients are still seizing. Again, there's some electrical discharges from the brain. If it's a generalized seizure, the whole brain is affected, which means both cerebral hemispheres. And sometimes it's obvious and there's convulsions, but sometimes they're just out of it, or they have a gaze preference. If you're in the rig and you give a seizure medicine and the obvious convulsions and whatnot stop, but they're still looking to the side, especially if they're not talking, they're still probably having a subclinical seizure. And most of these types of seizures here are bilateral, and again, they're usually unresponsive or not responding normally. Absence or petit mal, most of you have probably heard of that kind of a seizure. Interestingly, this is less common under age 5. With the video games and stuff like that, we see a lot more photosensitive seizures. And so the individuals may be stimulated by that. And then a lot of times there's eyelid flickering or blinking. And then the incredible thing is that these patients then resume things normally as if nothing happened. And so it makes it difficult to pick this up. And a lot of times it's a teacher at school. But eventually, these kids will start having sort of decline of their academic abilities or other things that someone eventually picks up on. And in retrospect, it's probably been going on for quite a while. And then, generalized tonic seizures, stiffness, rigidity, rhythmic shaking. It's usually symmetrical, but it can be asymmetrical. And we have clonic and tonic-clonic. So the difference there is clonic is the jerking movements, and then tonic is more stiffness. And so it's interesting. Sometimes we often see the arms will shake, eyes will blink, and then legs will be stiff. Or sometimes all the families will describe is a lot of stiffness in general, and then often when that seizure resolves, then they become limp. Neonatal seizures is definitely a subset of patients that you will see in the field. A lot of times infants, their first seizure will be at home. Sometimes the families don't know what they're seeing, and so it'll happen a few times, and then for whatever reason, they become either aware that it's a potential seizure, maybe a family member comes over, or they have an evolution of things, and so it becomes more obvious. The incidence is fairly low. There's many causes, and it can be electrolyte, it can be trauma, it can be, they have a seizure disorder. One of the things I want to make sure you think about is the potential for non-accidental trauma. Infants that are seizing and then unresponsive, you need to assume they're worst initially, because it's sad how often we see that. And so, don't forget to think about that and protecting the C-spine and other things in that situation. And a lot of times, infants have these reflexes, like moral reflexes and startle reflexes. So sometimes what the parents think is a seizure isn't. But again, it's better to assume it's a seizure to start with. And unfortunately, if you have a seizure as an infant, oftentimes that then means that you're going to have seizures for a long time. You want to focus on the underlying condition. I can't stress enough that hypoglycemia is something that's easy for you to recognize and easy for you to treat right there. So it's one thing you don't want to miss as far as a potential underlying condition. Other things will have to be diagnosed by us, but that's one thing that you might be able to see and help immediately. In addition, hypocalcemia is another one that we see often. Depending on who you talk to, you'll hear different opinions as to what specific seizure medicines you might want to use. Here's a list of some of the ones that are most common. It's true that most of us would probably use phenobarbital initially for an infant or neonate that's having a seizure. But again, the first thing we would do, to be honest, would be to check a sugar and then deal with that. One of the things that I've learned over the years you want to be aware of is anytime you give a seizure medicine, the patient can become apneic, and it's way more likely in this age group. So you want to be ready to intervene if that's the case, but you obviously don't want them to keep having a seizure. So check a sugar, consider phenobarb, though I'm not sure, do they have phenobarb in the rig? Okay, so you don't have that. So then, watch airway and kind of go from there, but please check a sugar. This is infantile spasms is a severe form of seizures in neonates. On an EEG, just kind of interesting, there's a specific type of sort of finding that they find, and unfortunately for these patients, they oftentimes have long-term major cognitive and other issues. Which of these medicines do they have on the rig? What's that? The top one? Okay. So diazepam, midazolam, or lorazepam. One of the things, my personal rule, and I recommend that you follow this, is I try not to get bogged down with remembering drug doses, okay? Because it's too easy to make a mistake. So Lila, who you know, has done a good job of creating these cards, and I assume everyone has the cards now. So you want to get the right size based on the color code and then use the dosing there. If you're trying to figure out and remember dosing, it's too likely that you might give the wrong dose. But knowing which medicines to give is helpful. I personally, as my first line, like to use Ativan as my main drug of choice because it works well and it lasts a while, so that I get what I need, which is time to get the seizure to end, and then I have time to then work on what's going on and figure out the underlying cause so that I can help with that. But midazolam is also a wonderful medicine. And then midazolam, one of the things that's nice about it is that you can give it intranasally. And you guys have intranasal midazolam? Yeah, so you have it in your rigs. It's a wonderful medicine, and for me, that would be probably in the rig, that's what I would do initially. There should be guidance again using the cards for dosing. You can call us. We also have the cards right next to our base station. And what I do is I double check what the weight, I look at the dose, and then I double check that it seems reasonable mentally before acknowledging that's what we should do. There's a little range of dosing, and I'm just going to go on as a side again. You should use the card, okay? But if there's an option of 2 doses, I personally will use the lower dose first with a plan to use a second dose later because, again, in my experience, I don't want the patient to be going into respiratory depression. You don't want to have to intubate them on the way to us if you can avoid it. So a nice, adequate, safe, appropriate dose initially with a plan to potentially use a second dose is a better strategy than really giving a huge dose to start with and then having to backpedal later. Most of these other medicines you don't have. But just so you know what we would do, we would give Ativan probably, or if we don't have it, easily accessible or IV access or whatnot, we would potentially use intranasal midazolam or IV. And then you used to do other things, but actually what we often do now is do Keppra in the older kids. Again, in the younger kids we use phenobarb, but Keppra is something that even over the last 5 years has become the go-to medicine. But there's several other options that we can use on a case-by-case basis. If Keppra doesn't work, oftentimes what I use is probably phosphonatoin next, but everyone has their own style. We don't normally jump right to propofol, but it's a nice medicine to have in the arsenal, and it might affect how I might use it if I need to intubate or something like that. But you don't have propofol in the rigs, correct? Right, yeah.
No. Doc, how do you feel about the use of ketamine for potentially refractory seizures?
So I wouldn't normally use ketamine in that situation. One of the things that ketamine does, and again, I'm trying to avoid having to intubate and other things, and ketamine causes a lot of laryngospasm, and it causes you to have increased salivation and whatnot. And so a patient that's already potentially having a difficult airway to begin with, because of secretions and other things might be biting their tongue. For me, I probably wouldn't use it in that setting. The other thing that ketamine has a contraindication about is that it can increase your ICP. And so unfortunately, like I mentioned earlier, a lot of these patients are trauma victims and they're shaken or whatnot. And the ketamine is contraindicated in that situation as well. Okay, so how's my time looking? Pretty good, okay. Again, we can go over the mechanisms and things like that, but I'm not sure that's as helpful as knowing which medicines to use. Rectal diastat is something we used to use a lot of, and it's another option. Oftentimes, 2 years ago, the patients' families that had known seizure disorders would have given the rectal diastat, okay? The last couple of years, though, the intranasal midazolam, we've been prescribing that more. So that's usually what they're getting. But this is a good option, especially if you don't have an IV. But do you have that on the rigs or no? Rectal diastat? No. So it might be a situation where you potentially give the patient's own medicine. That seems unlikely. We talked about Ativan. Again, it's potent. It works really well. It takes about 3 minutes. So I usually give a little time, up to 5 minutes for it to kick in. And it lasts for quite a while. Versed, again, intranasally is wonderful, but you can give it in any of, IV, IO, or IM, but it doesn't last quite as long. Hopefully, though, by the time you get here, question? Oh.
Yeah, Doc, I have a quick question online, and this ties into your discussion on Versed. The question is, when the patient stops convulsing, but you notice their eyes have a right or left gait, is the seizure getting worse or better or just different? Does this patient still need to be treated with Versed?
Okay. So that's an excellent question. I think the patient is getting better, but they're not completely home free. So what I would typically do is give them about 5 minutes minimum between when we initiated the med and keep watching them carefully. If you're in a situation where the dosing that you gave initially was a smaller dose, then you could safely give a second dose if they're still having a gaze preference. If you're within 5 minutes of us, I would still wait, because most of the time when you have a gaze preference like that, your respirations, other things are improved. And that's why I think it's an improvement versus the original situation. And again, you're balancing whether to sort of treat the seizure or bridge them to us and minimize any respiratory depression. I mentioned that I don't normally think of dosing necessarily, but again, it's helpful to use a slightly lower dose initially so you can have a backup dose, but use the card as your guide. So, yeah. Let me see here if there's anything else. Okay, so please start asking as many questions as you can. I think we've got another 10 minutes or so. So, and I'm going to just go over practically what I would be thinking about if I went into a house where a patient was having a seizure, okay? ABCs still hold, okay? And so the most important thing you want to do, when you go into a home where there's a seizure happening, most likely the family will be in a panic or at least super anxious about things. So the first step is to put the patient into a safe position. Be aware that their tongue, I always talk to patients when I meet them in the ER, you're not going to swallow your tongue, as everyone knows, but the tongue can obstruct your airway. If you can do a little, repositioning of the mouth so the tongue comes off the top of the roof of the mouth, that's helpful, but more often than not, while maintaining C-spine precautions, if there's any question whatsoever of trauma, you want to adjust things so that you can get air in there, and sometimes you may have to do a little bagging or something to get their airway, more secure. Oftentimes, patients will vomit, when they're having a seizure, and so the first thing, like anything else, is you want to protect the airway, because if you protect the airway, then the patient's going to have a much higher likelihood of doing well. Then assess the situation. Okay, if it's an infant, you want to think about sugar. Okay, you want to think about glucose, and you have the ability to do that on most rigs. Okay, so keep that in mind and check that as soon as you can. And then access, right? The beauty of it is, like I mentioned already, you don't have to have access to help this patient necessarily. So you can give intranasal midazolam, and the way I would look at it, if they're actively seizing. Initially, that's the way you want to think about. If they're not actively seizing, then take a sugar and then get them on the way to us, okay? If they don't have another seizure and aren't actively seizing, I don't think you necessarily have to give any seizure medicine. But kind of think about that on your way here. Sadly, again, I can't reiterate enough the importance of thinking about non-accidental trauma. Anyone that's less than 5 and is unresponsive or acting weird for no reason, that's number one option until proven otherwise. You want to make sure you mobilize the C-spine. Do you guys? The other thing is, if they're having a febrile seizure, D-stick and temperature. If they have a temperature, my high recommendation is at some point when you've dealt with everything else, you want to treat that fever, okay? Because the fever is what's driving the seizure. The best way to do it is rectal Tylenol. Do you have that on the rigs? No? Okay. If you don't have that, then you have to decide whether it's safe to give an oral dose of Tylenol. If someone's actively seizing or vomiting, you don't necessarily want to do that because they may throw it up. But again, if you can't treat the fever, if you're comfortable with them being able to swallow it, then feel it. Yeah.
Dr. Flaskerud, could you just comment a little bit more about febrile seizures and what would be the appropriate thing to tell a family when the crews respond, given families are worried about brain injury, about this being meningitis or encephalitis, and this is a very common transport call. So maybe if you could just expand a little bit more on the febrile seizures, that'd be awesome.
So I'll give you the spiel that I normally do with the patients that have come in. The family is super freaked out. Okay, they're usually extremely anxious about it. My niece, one time when she was a year old, had a seizure on a plane going from Sacramento to here, and they actually turned the plane around for her. The good news is these patients are going to do really well. Okay, but a few key points about a febrile seizure. Normally, a febrile seizure is in patients less than 5 or 6. So if you're 7, 8, 9 or higher in age, it's probably not a simple febrile seizure. We differentiate between simple febrile seizures, with the seizures that have occurred once in the last 24 hours or maybe twice, but the old definition was once. And if you have a seizure, that seizure should last in less than 15 minutes. And the patient should return to their baseline, and it should be non-focal. So if you have a patient who's 6 or less, had a seizure that lasted less than 15 minutes, has a known fever, and is completely back to the baseline, and the seizure was non-focal, this is what I tell the families. The good news is your brain's going to be fine. Okay, the kid's going to do awesome. We see this all the time. Secondly, unfortunately, a third of people that have had a febrile seizure once will have another one. So you need, I kind of go through what to look for in the future. But the good news is, in the general population, 1 in 100 people have seizures ongoing called epilepsy, okay? But only 2 in 100 that have had a febrile seizure end up having epilepsy. So this does not mean that your child is going to keep having febrile seizures and other seizures throughout their life, necessarily. 3 is, you want to try any illness until they reach around 5 or 6 to give ibuprofen pretty regularly to try to get ahead of the fever. But you can't feel bad if they have a fever and get a seizure anyway, because sometimes that happens. If it's the first febrile seizure, I recommend that you bring that patient to us. Okay? If they've had a third febrile seizure, and this is the family that's really comfortable and you feel that you can rely on them, and you don't think there's anything else going on that needs us to help them, that patient could potentially stay home, but you always need to call us. The second seizure is a gray zone. But the red flags, again, are a seizure greater than 15 minutes, a focal seizure, in other words, one part of it, or even a gaze preference to one side, one body part or one side, that needs to come to us. If the patient is not waking up and is still out of it, okay, they need to come to us as well. And there's going to be a gray zone there, but they should bounce back pretty quickly. So hopefully that'll answer a lot of your questions about it. But any other specific ideas about that or questions? Okay.
All right, Doc, thank you. That concludes. We have no further questions online. And it looks like we're going to be taking a break till 12:20, about 10 minutes. Thank you.
Thank you, Dr. Flaskerud. That was a great talk. I just wanted to briefly highlight the pediatric cards that Dr. Flaskerud was talking about. Here in my left hand, you see an example of these cards. These are available throughout Pierce County. They're fantastic, and their goal really is to help support what you all do in the field to reduce cognitive load, give you correct dosing, equipment size, vital signs, bolus dosing. You have airway equipment size on here, as well as depth of endotracheal tube, for instance. The Broslow tape is attached to the card, so you measure the patient, you get a color, and then each card is a Broslow color and goes through everything very succinctly. If you do not have these cards, certainly talk to your leadership within your own agency. They're fantastic. Without further ado, I want to introduce our last speaker, Dr. Cassie Long. She's one of my fabulous colleagues at Marybridge Emergency Department. She is from Pennsylvania. We are lucky to have her out here on the West Coast. She trained at Children's Hospital of Philadelphia and has been with Marybridge for 2 years. Today, she's going to talk to us about pediatric head trauma. Dr. Long?
Thank you very much, Dr. O, for that introduction. Okay, as we're rounding the bout into the afternoon, last talk, hopefully everyone got a nice 10-minute break. Today we're going to discuss pediatric head trauma, and I chose this picture because I think it illustrates quite frequently how our young children like to get into things and often fall, hit their heads, or pull things on top of themselves. So I'm going to give you a brief overview of just head trauma statistics. So traumatic brain injury is actually the leading cause of pediatric trauma death. Primarily, injuries are sustained through falls or through motor vehicle collisions, but physical abuse also plays in as a large mechanism in children who are less than 1 of age. Gratefully, the majority of pediatric head trauma is considered minor in nature. Most studies cite about a 4.5% required admission. So that means the vast majority of kids who hit their head or sustain a head injury don't require hospitalization. Highest mortality in kids with head trauma is associated with those children who are less than 4 and have hypotension upon presentation. So those are the ones you really want to watch out for. There's several different types of brain injury. We're going to go over each of them quickly just so we all have the same language on board. The most common type of severe traumatic brain injury is diffuse brain injury or diffuse axonal injury, which basically results from a shearing force of the gray-white matter. Typically happens when you have kind of an impact as well as that causes an acceleration and then subsequently a very quick deceleration. This also falls into where you see your shaken baby syndromes occurring, where they have that forceful forward, maybe hit on a ledge, and then have the deceleration at the same time. For those of you who are visual, like myself, it's a lot easier to get this concept when you look at a picture of what's actually going on. So if you look at the detailed view of what's happening between the white matter on the left and the gray matter, which looks more pink to me in this picture than anything else, on the right, you actually can get a few different types of injuries. You can get stretching or pulling of those axons or the nerves that you see at the top. You can get a tearing of the juncture or complete shearing or break. And this is where you're getting kind of a brain injury that's traumatic in nature but doesn't associate itself with the typical bleeding that you might always associate with traumatic brain injury. So now we're going to talk a little bit about focal brain injuries. There can be brain contusions. This is usually when there's a kind of contra coup action where you have an acceleration and a deceleration and the brain is moving forward and backwards at a very fast rate. There can be intraparenchymal hemorrhages where you've got tearing actually going on within the tissue itself. You can get a subdural hematoma, which has to do with kind of venous tearing. You see that on the left upper side. Or an epidural, which can sometimes be ulterior and sometimes be venous. And that one classically has that period where the child or the patient is lucid, seems totally fine, and then rapidly decompensates, and that's why. And then you can get a subarachnoid hemorrhage, which is also kind of associated with a tear. So let's talk a little bit about pediatric trauma patients. So often if you encounter a child with severe traumatic brain injury, and I'm going to zero in more on severe traumatic brain injury for a large majority of the rest of the talk, usually their injury is going to be complicated by multiple other injuries because whatever occurred to them probably didn't occur in isolation. So with kids with severe traumatic brain injury, you're going to want to be keeping in mind that 2/3 of them, so the vast majority, have another injury that you should be looking for and thinking about in your management strategies. Also, you want to know that while we always immobilize these kids, only 1% to 2% of them with any type of blunt trauma, any type of fall, will actually have a cervical spine injury. But in your severe traumatic brain injury kids, those who have persistent altered mental status or remain intubated 72 hours after injury, about 1/3 of those actually do have an associated cervical spine consideration. So we always take the precaution in the field because you do not know. And these kids are often altered and cannot tell you. And you put that C-spine in place just in case, even though it is exceedingly rare. So before I deep dive into the severe traumatic brain injury, I just wanted to remind everybody about the vast majority of kids who hit their heads who don't have a traumatic brain injury, and therefore when they come to us, they fall under these PCARN rules of head trauma. So we are very fortunate. We have very few robust studies in children, but this is one of them that looked at thousands and thousands of children who hit their head and tried to tease out risk factors that made them likely to have a clinically significant bleed. And that's defined as a bleed in their brain that requires some type of neurosurgical intervention. And that's something I think that a lot of people get confused because there's a lot of decision rules out there and people will reference the PCARN head trauma rules and say, oh, it tells you who to CT, who not to CT. That's not the case. It tells you who's at risk for something that's going to be clinically significant that's going to require a neurosurgical intervention. And so when you look at these rules, it's divided into 2 separate categories. One is for children less than 2, obviously because they have different risk factors, but also because of their stature, and then those who are greater than 2. The vast majority of the rules, so looking at them, if you read these off, these are what put you at low risk for an injury. So you have a normal mental status on presentation. You don't have a large hematoma, or it's just on the front of your head because that frontal bone is really, really hard. It's also where kids tend to fall. The child has not lost consciousness, or if they did, it was brief, less than 5 seconds. There's no palpable skull fracture on your exam, and they're acting normally to the parents. That's for less than 2. And then for greater than 2, again, normal mental status, no loss of consciousness. Here's where vomiting plays in. No vomiting, though I will say that we do tweak that a little bit with the kids that we see in the emergency department, and we do permit sometimes some post-impact vomiting initially, as long as it doesn't progress or become persistent. And then no sign of a basilar skull fracture. I'll show you one keen sign of a basilar skull fracture, and no severe or intense headache. And then the other 2 differences between the ages is when you look at what's considered to be a severe versus non-severe mechanism of injury. So both of them agree that as long as, if they were in a motor vehicle collision, as long as there's no injection, death, rollover, or the child was not struck by a car or struck on a bike by a car without a helmet, those are all considered non-severe mechanisms. And then the big difference comes in the height. So less than 2, if they fall 3 feet or greater, that's considered outside of the scope of a non-severe injury of mechanism. Again, doesn't mean they have to be CT'd, but just when you're weighing all the risk factors together, that factors in. And when they're greater than 2 or equal to 2, it's got to be at least 5 feet to be considered more severe. So let's start with a case, and then we'll walk through kind of presentation management and tease out some different points with severe traumatic brain injury. So you get a call, you have a 7-year-old male who got kicked in the head by a horse, by a Clydesdale, while out in the pasture. This is a real case. You arrive on scene, your temperature's normal or smidge tachycardic, but otherwise pretty stable. He's lying in a field, his eyes open when you yell at him. He's bleeding from a large laceration to the left side of his head, and he's got some blood coming out of his ear. Heart and lungs sound fine. He seems to localize to pain, but he's a little bit confused when you talk to him. So, initial assessment. So of course, scene safety, right? You guys are the kings at this. I feel like in the ER, we are not. We, especially with COVID, we rush in there and then we realize, oh, we got to put all this stuff on. You guys do this way better than we do. So I just wanted to put it out there. But in case anyone's wondering, the horses are secure. You just have the patient to worry about. And then you want to go with stop the bleed, right? This kid has a large laceration on the left side of his head. Kids, especially young ones, are actually at risk for losing a significant amount of blood from large head traumas. And that can be because it's so high, their heads are so highly vascular and take up such a large component of their total body mass. And then you're going to go through your typical trauma assessment, which is your ABCDEs. We'll go over those. So if you remember the Glasgow Coma Scale off the top of the head, you are a hero. I cannot. And I don't know many people who do, but it really does help factor in. So if you can keep an easy, pediatric version of it on your person so that you can just go through and kind of tick it off, that's probably the easiest way to go. So if you remember, this child is greater than 1. They were able to open their eyes to shouting, so that gives them a 3. They can localize to pain, it's a 5, and they're confused. So that's a 4. So that comes up with 5, 4, 12. So you have a GCS of 12 right now. Yeah. And then that puts you at kind of the moderate head trauma. If you look to the right, we have mild, moderate, and severe laid out based on GCS. So that'll help you when you're calling into your station saying, hey, I've got this kid, GCS 12. They know that they've got to be a little bit more concerned about this child than someone else. Also helps to play a little bit into your role of where you're going to take this kid. Of course, you guys have that really, really hard decision of where to take your patients and kind of triaging in the field how emergent something is and if you need to go to the closest hospital versus hold out for a pediatric trauma center. And so one of the things that the experts say is if your field evaluation shows a GCS equal to or less than 12, that patient would likely, if possible, benefit from being at a pediatric trauma center. Or if they have a trauma score, which is mostly based on vital signs. I don't know if you guys use it or not, but if you have a trauma score that's less than or equal to 8, I don't know anybody outside of trauma surgeons that tend to use that. And then if you're at an outside hospital and you're transporting a kid, some of the criteria they may have used in order to initiate that transport to a pediatric trauma center after stabilization is if the child has a persistent GCS that's less than or equal to 8, a GCS that's less than or equal to 12 and has some associated major injuries that their facility can't handle, or more importantly, if they're deteriorating in condition or rapidly deteriorating in their GCS. So you've done your job. You've stopped the bleed. Your C-spine's immobilized. You put supplemental oxygen. All trauma patients get supplemental oxygen. A patient that's awake and alert with normal vital signs, a simple face mask is absolutely adequate, but it helps to decrease any metabolic demands that the patient might be having as a result of the trauma. You're establishing an IV, preferably the largest you can get depending on the patient. I know in kids, we always like the hands and stuff. This trauma patient is not the patient you're going for the hands. This is where you're going for the AC and you're trying to get access so you can get your fluids in. You're going to give probably around as much as you can, up to 20 ml per kilogram of normal saline just to get some fluids on board. And then you may or may not decide you want to give this child some pain control, morphine, fentanyl, whatever you have, or Zofran for nausea. So you're in the back of the rig. Things are going okay. You're diligent, so you know you need to reassess this patient every 5 to 10 minutes, make sure that things are not changing. And now you can just do your simple trauma survey where you're doing your airway, which is still patent. You see that your vital signs are a little bit different, but still adequate. They're breathing spontaneously, good circulation, but now the patient's neurostatus has significantly deteriorated. They're moaning, they're incomprehensible. Their eyes still open to pain and they still withdraw to pain, but they're declining kind of in their mental status significantly. You check their pupils, which is always good to remember, okay? So in addition to these other things, you want to check your pupils, make sure there's no asymmetry, and they're equal. So back to our Glasgow Coma Scale. So now we're opening to pain, so we're a 2. We're withdrawing to pain, so we're a 4, 6. But we're kind of making these like incomprehensible sounds. So now we're more down towards an 8. So we're getting into the more severe, and we've had an acute change in our GCS since this started. So now you're going to want to start thinking about, do I need to establish an airway, right? Because this child is having a rapidly declining GCS. And so what are your indications for kind of establishing an airway in a severe traumatic brain injury? So one of them is exactly what we're talking about, decreasing level of consciousness or rapidly falling GCS. Also, if you have any signs of respiratory failure, loss of your gag reflex, not protecting your airway anymore, or if your patient is suddenly becoming very hemodynamically unstable and you feel like you need to protect their airway for their safety. Some of the things that you're considering as you're going through your head, okay, great, now I got to establish a tube on this kid, is when I go to intubate, I need to maintain C-spine precautions. How am I going to do that? And so there's a couple different ways to do it, depending on how many hands you have. But it's always a challenge to maintain the C-spine precautions, whether it's you try to intubate with the collar on or you have a colleague that can help immobilize the spine while you're intubating, and you can take the collar down safely while they hold C-spine, and that's probably the easiest for everybody. And then just a gentle reminder, I'm sure you guys all know that with pediatric trauma and with most pediatric patients, a cuffed ET tube is now preferred. Okay, so let's talk about RSI considerations. And we got our little quote by Benjamin Franklin: by failing to prepare, you are preparing to fail. And so I'm going to talk through medicines, I'm going to talk through those types of things, but if you look at the people who consider themselves really good at getting airways, their biggest step is preparing, right? And making sure they have all their things lined up and they know what they're going to do if and when they fail. And so you're going to want to assess your airway limitations. In kids, you can have small jaws, large tongues, all sorts of different things. So you want to make sure you're optimizing that patient's position as much as you can so that you can get a good view. You want to think about your different RSI medications and what the risks and benefits of each one might be, and kind of weigh in your mind which one you think would best benefit this patient. You want to check your equipment, make sure it's functioning before you use it, right? Because that can be a big thing. You know, you go to intubate and your light's not working, or you didn't have your backup tube. And then you want to know, okay, if I can't get this airway, what am I going to do? What's my next step? Do I have a LMA? Do I have a King? Do I have, am I going to bag and let them know? Because I bagged just fine before and could get them there in time. And so just knowing between you and your team what your next steps are going to be. You want to pre-oxygenate this patient. If they're spontaneously breathing, you can just use the non-rebreather. If it's inadequate or apneic, you can use the BVM. And then you want to think about any pre-treatment medications, the sedation, and your paralytic, which we'll talk about next. So in the case of severe traumatic brain injury, there's some literature out there that suggests that lidocaine use 1 milligram per kilogram 2 to 3 minutes prior to intubation can help minimize any increased ICP that may occur with airway manipulation. You will not be faulted for it. You will not be faulted for not doing it. It's just another tool in your toolbox that you can try if you've got the time and you've got the medication. It's not been robustly studied. There's minimal evidence that it is beneficial, but again, it would have to be given more in the 2 to 3 minute time period. So, as you're pre-oxygenating and have your meds drawn and setting up, you could consider giving it at that time. Let's talk about your induction agents. Etomidate is a clear favorite in the traumatic pediatric head trauma and in trauma in general, I would say. And that's going to be a dosing of 0.3 mg per kg. If you look at your PALS, or you look at your sepsis, or you look at your other kind of indications where you intubate a child, they'll steer you away from etomidate because of transient suppression in the adrenal glands. But that's not the case, or we don't care about it as much, I guess I should say, in trauma. And this is going to be the one that's going to keep your blood pressure and your heart rate as stable as possible to allow you to do what you need to do. Other people have suggested ketamine as a potential medication to use for induction. It's also a good choice. There's some theoretical risk of increased ICP or blood pressure effects, which were actually, the increased ICP is one robust study indicated that it doesn't occur quite to the extent that we thought. But it can cause some increased ocular pressure. So that's also something to consider if you've got a kid with eye involvement as well. And then when it comes to your paralytics, there's usually two basic choices. Rocuronium is the one that we love in the emergency department. We use what we love and know at 1 mg per kg, and that's probably your best go-to. If you don't have it, succinylcholine is also acceptable. Notice that there's 2 different dosing depend on age. There's just a lot of different factors that play into using Sux, which is why it's not preferred over rock. But one of them is if you have a kid with any type of crush injury, you definitely want to avoid succinylcholine. So you've got the child intubated, you're almost at the hospital. What are your goals? Your goals are to keep everything normal. That's it. That's all you got to do. Normal oxygen level, normal blood pressure, don't overbag. You want to keep it at a normal intubated goal of, a PaCO2 of 35 to 40, as long as your child's not showing any signs of herniation. And you want to make sure you're keeping them at a normal temperature. So really, even when this child gets to the hospital, the majority of things are going to be keeping everything about this child as normal to physiological baseline as possible. So you're at the hospital. Whew, thank goodness. I'm getting tense already. So now you're going to notice something very distinct about your vital signs. They've changed significantly as you arrive in the bay. And for a kid who's got a severe head trauma, you wouldn't expect their heart rate to be 80 and their blood pressure to be 140/87. That's pretty low for a heart rate and pretty high for a blood pressure in this particular child. Now the child is now sedated and paralyzed, so your exam is not going to really show that much, except you look at the pupils and now you see that you've got your right-sided pupil significantly dilated compared to your left. So what are we all thinking? So we're all thinking about clinical signs of impending herniation. So what are some of those? So it can be hypertension with or without bradycardia, anisocoria, which is also known as just unequal pupils, which in a kid that's otherwise well-appearing with a minor head trauma, you might not get too excited about because there is a portion of the population at baseline that have anisocoria. So there has been a kid or two that's come in with a minor head trauma where I've asked parents if this looks normal to them, and if they don't know, I've asked to look at previous photos to see if they at baseline have unequal sides. But of course, this is not this patient. They might have a severe headache, they might be in a coma, they might have abnormal breathing, they might have some weakness on one side or be posturing. And so what is the big deal about all this? What's the low heart rate, high blood pressure, impending herniation? Why does that happen? So why that happens is something in the body called Cushing's reflex. And basically what happens is your hypothalamus responds to brain ischemia. It activates your sympathetic nervous system that results in increasing in your peripheral blood vessels, which increases in their resistance, which increases your blood pressure. In response to that, your blood pressure goes up and your parasympathetic nervous system, which is in your carotid sensors, puts your heart rate down and you become bradycardic. The thing that we worry about with severe head trauma, blood pressure going up, heart rate going down, is it can lead to this clinical presentation of Cushing's triad, which is high blood pressure, low heart rate, and irregular respirations, also known as Cheney-Stokes respirations. And why this matters and why you have to recognize it is when you get Cushing's triad, it signals to you as a clinical provider that your brain may be at risk for herniation. What do you do about it? So you're noticing that this is happening. So this is when you switch from normal ventilation to hyperventilation for a period of time. You might consider elevating your head of bed 50 to 30 degrees. It probably has minimal impact, but can't hurt. And then you're thinking about giving one of two agents to help with any swelling or increased pressure. One is mannitol and the other is normal hypertonic saline. or 3% normal saline. Mannitol is the traditional one that a lot of people used, but can cause some diuresis afterwards. So lately we've kind of switched towards using 3% normal saline at 5 ml per kilogram because of less side effects and just as beneficial. I've been asked before as fast as you can go with the normal saline, the 3%. It's push. And then what's going to happen with this child? Well, they'll get a head CT. They'll probably get anti-seizure prophylaxis because if these kids have seizures, it can cause worsening brain loss and swelling. Neurosurgical consult. They'll get some type of intracranial pressure monitor so people will know how they're doing. And then ultimately, if those pressures aren't controlled or there's a bleed on their CT scan that requires intervention, they'll get evacuated or decompressed. So just a little bit more to round us out. So we should remember that there are two insults when it comes to traumatic brain injury. The first one's the primary insult, which is the direct trauma that occurs to the brain. We as providers have no control over that. Why you want to try to keep everything normal and optimize, your oxygenation and your circulation is what we have a little control over is the secondary injury or the biochemical cascade and inflammation and swelling that occur after the initial injury. In kids, cerebral swelling usually peaks at the 24 to 72 hour mark. So this kid will be in the hospital for a prolonged period of time, kind of seeing what their outcome is like. And the reason that swelling is a little more common in kids with severe TPI than your adult population is that infants have more pliable skulls, meaning that they're less likely to fracture, more likely to have bleed and swelling. And then there's just less space actually in pediatric skulls because brain atrophy doesn't start until adolescence. So how's this patient going to do? Well, there was one large study that looked at almost 200 children with severe traumatic brain injury who had a median arrival GCS of 3 in the ED. And just remember that even the table has a GCS of 3. And on presentation to the ICU had a GCS of 6. 80% of those kids survived to discharge, and 68% of them had what was considered favorable discharge dispositions, meaning they either went home or they went to rehab. So with proper care, Pegasus looks at like the standard of care, which we had just discussed, being given to these children. They actually did quite well, and you were a big part of that. So thank you guys. That's all I have. Thank you for all I do. You do. I do. Everyone does. And questions.
All right. Thank you, Doc. Quick questions in terms of CO2 levels.
Yeah.
When we talk about a severe pediatric trauma patient, as the case study presents, all of us kind of, most of us can kind of predict the future. We've got a significant transition of GCS as appropriately used to say, hey, we've got this dramatic change in GCS. We're in the field, we're transporting to Mary Bridge, our trauma center. We know we've identified this as a step 1 patient. You give clear guidance to say, hey, let's titrate our CO2 levels to normal. Is there value in, since we know where this is going, to start titrating CO2 levels earlier because it's such a consistent tool that we're using? Say, hey, let's keep it at 30. And so when we transfer care, we can say, hey, we know where this is going. We're already titrating CO2 levels. Do you think there's value in that? Or just we should wait till we have signs of herniation?
You should wait till you have signs of herniation because you can cause some ischemia by doing it too soon. And with the really dropping it down to 30 to 35 is really when you feel like your patient is herniating in front of you. And that's when you have a real concern. Otherwise, you want to keep it normal.
Excellent. Thank you.
Yeah.
Thank you, Dr. Long. That was fabulous. I have one quick update for those of you who are asking right now with regards to the Mary Bridge Base Station contact information. That issue has been resolved as of last night, so you should be able to use your regular phone contact to the Mary Bridge Base Station that is already programmed into your phones. It is, for those of you who don't know, it's 253-403-1476. And the other number, which is the ER ambulance line, is 253-403-4444. And if there's any questions with regards to any of this, please contact me either by my phone or by email. Thank you very much.
I just want to say a special thank you to Dr. O for pulling this all together for us. I'd like to say thank you for all the physicians that came and shared your knowledge with us today. We appreciate it. I'd like to say thank you to everyone who watched throughout the county. I hope you found it useful and helpful. If you want a recording of this, please reach out to me. I'm Joe Bouchard at Central Pierce, or my EMS captain, Jesse Fox. I think that about wraps it up. Thank you, everyone. Be safe. Have a good weekend.